Huh? Why is the calendar?
Put it on the start.
Mike.
This.
So just 6 months. Okay. I cannot go anywhere else. I'm going to also.
Just very steady picture.
Wait, they've not started now. They've not started.
Wait, somebody's looking.
Hello. Hello, can you hear me?
Some people have some people have
Hello.
Hello, we can hear you.
Okay, I can hear you now. Hello. Hello.
Sir, we can hear you.
Okay, I'm with you now. Have you started? Okay, yeah.
Oh, Papa, Abu gobe za mu haɗu a church kuma. Kaga mun gaishe shi mun gama kenan. Ina. Da yawa a tun na shiga gidan can ina ta cirewa ne. Kabewa da. Na gan shi. A'a, sun cire masara sai gero ya bi bayan shi. Oh. Nan ma the same thing fa. Wannan mutane. Sun harvesting ma dai. Ai ba ko ɗaya sama. Ya aza laɓuya shi. Kafin da cuta bai dame shi ba wannan shekara. Mutum ma cuta ya dame shi. Ai tumatir na wayan
Good morning. Sorry, we will soon start. Sorry for the delay, please. We will be starting soon, please.
Nasu manya manya.
Can you hear me, please?
Ka ga wannan variety. Kamar ruwa jiya nan ya kwantar musu.
Yeah, we can
Yes, we
hear
are
you.
hearing you. We are hearing
morning.
you.
We are sorry for the delay.
Baji.
Starting soon.
Zai siyar mana tumatir din. Ga ɗaya ɗaya zai cire. Ga su nan a kasa su fari. Ya shiga wannan baban. Ga rawan su yayi. Ya mai a sama.
So before starting, if anyone has anything to comment, can on ways to improve the workshop delivery. You are welcome to comment. We will soon start, please. Just bear with us. We have not started yet.
Ebe a gasala tem no.
Fine. Right on.
Good morning, everyone. Good morning.
Good morning, sir.
Okay, we are once again sorry for the delay. We are busy with trying to uh, uh, connect to the network. It was a bit slow, but thank God we are on it now. We are going to start with the first item on the module, general assessments in pediatric physiotherapy. You know, when you say pediatric physiotherapy, it's like combining neuro, auto, cardio all together in one specialty. That is what makes neuro, what do you call it? That makes pediatric specialty a different one. Therefore, general assessment actually may involve a lot of things, but we may not be able to cover everything. But by God's grace, we are going to do justice to the topic. We said assessment, by way of introduction, we said assessment is an ongoing process and it can take place throughout the period of pediatric physiotherapy. What we mean here is that when we have a child before us as physiotherapists, uh, we should know that the assessment of the child and coming up with what do you call it, definite diagnosis may not take place the first day the child arrived. Probably we may have an impression, and then we probably need uh, 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 further assessment. We may need further laboratory tests. We may need some time to look at some differential diagnosis. That is why it is an ongoing process. After some time, we now come up with that we a definite plan for the patient. And even in general practice, at times when you see a medical doctor, like for example in the GOPD, you may be having some chest pain. Yes, at the first instance, the medic will now give you drugs that will give relieve the pain, but you have to undergo some tests to differentiate what is actually the cause of this pain. With time, they will now come to realize that is it something that he can handle, or he has to refer you, is it to a pulmonologist, or he will refer you to an orthopedic surgeon. That is the same thing with physiotherapy. It's an ongoing process. Therefore, one cannot start what do you call it, assessment today and finish the assessment today. It is actually unrealistic. Then we said the aim of assessment is to establish parameters for initial intervention. Yes, we have to establish that this guy have a reduction in range of motion. Therefore, the initial intervention for physiotherapy is that we want to improve range of motion. There is pain. There is probably a delayed milestone. The child will not be able, is unable to sit at the age of 8 months. Therefore, our probably first target is to help. It's not just the diagnosis, but there is something we saw. We have to establish initial, what do you call it, intervention. Then to agree on priorities for future therapy. Yes, actually, based on what I saw, what we likely, that is why we used to have short-term and long-term goals. What are the likely long-term goals for this child? Then monitor changes and progress. That is what brings about the issue of what outcomes. When we use validated outcomes, we know where we start. And then we now use outcomes that are responsive to change. The biggest example we used to cite is gross muscle power grading. That is the Oxford muscle power grading or the Medical Research Council scale. It's very common if you're typing and it has been validated. I start with somebody having a power of 2, or let's say I start with a gross motor function measure of so. Then the child now has improved to so. I have monitored the changes. I can easily say this is the changes we have realized objectively. Then evaluate outcomes. These are part of what are the outcomes you need to evaluate in all the children you see. What are the outcomes that are peculiar to orthopedics? What are the outcomes that are peculiar to neuro? What are the outcomes that are peculiar to cardio? And then how do we appropriately assess these ones? The next is assessment process. Yes, the assessment process, there is something that is very, very important. No matter how much you read, it will only add to your ability to take very good history. Yes. And this one actually comes with practice. Every day, one is assessing patients. We found out that why I used to take time when I was an intern to clerk a patient, because I really don't know the specific questions I should ask. Somebody coming with Erb's palsy, what are the specific questions I should ask? Somebody coming with what do you call it, CP, what are the specific questions I should ask? Somebody coming with diagnosis of cancer, what are the specific questions I should ask? Therefore, this issue of history taking depends on the condition you are taking, this based on the first impression you have, because definitely you ask some vital questions that would help in your diagnosis. Then this will now be preceded by physical assessment. What are the things I'm going to assess in this child? This is pediatrics. Therefore, what are the things we are really going to assess in this child? Then outcome assessment. We said in order for us to fast track the changes we see in the children, at times it's like casually we say, okay, the child has improved. But if I am sending this patient to a specialist somewhere in the UK, how do I tell him that I have given him 10 sessions of physiotherapy and there is improvement? I should talk to him using outcome measures that are valid and reliable, that could definitely now speak to him that yes, this guy has improved in the physiotherapy he received in Nigeria. Therefore, if we now start by going over the history, we said we need detailed prenatal, natal, and postnatal history. Yes, if we think the child's condition has something to do with what do you call it, pregnancy related issues, then definitely you are going to ask about the pregnancy related issues, whether the mother has been going to antenatal, whether the age at which the mother started, the month of the pregnancy at which the mother started going for antenatal, did she deliver in the hospital? She will begin to ask so many questions like that. And the natal cases, probably we ask about whether there is prolonged labor, whether there is what do you call it? Apart from prolonged labor, we ask about whether there is uh, 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 bleeding, that is postpartum hemorrhage, whether there is what do you call it, premature rupture of membranes, and houses they call it fire. The woman see water coming, and if they didn't go to the hospital after some time, infection may set in and may affect the child. So many things you ask about whether the child has cried, some of these things, so many things like that. Then postnatal history, probably ask about the history of jaundice. All these ones are very, very important. Therefore, we will now keep all these things that we know. We say we should add reasons for referral. Reasons for referral. I used to give this story that somebody came with his child and he was asking those at Ray Physiotherapy Institute that they should tell him what they will do to the child. And they now call me. The child has Erb's palsy. I was asking him, why did they refer? He said, yes. What have they done in the hospital? He now began to tell me that the doctor actually, after realizing that the child has Erb's palsy, where the wife, where the mother puts to bed, that the child, the mother, the consultant kept asking them to raise their hand, that after 3 weeks, the child is going to do well. But by the time I assessed the child, atrophy has started setting in deltoid and everything. I said, okay, this guy, I told him the truth. We are really going to manage the complication that arise as a result of mismanagement by non-specialist. The doctor that sent you to our place is a non-specialist. Therefore, reason for referral, why they refer because they have seen that there is damage. Reason for referral can be so many things. Then we now have immunization history. Probably if there are conditions that are associated with lack of immunization, you note. Then medication history, which is this thing is very, very important. Is the child taking medication for epilepsy? Immediately you see medication for epilepsy, you know this child is having epilepsy. Then you know how to handle him. Medications for what do you call it? Sleep, what do you call it? Tablets. Probably the mother has told medication for spasticity. You have to note the medication this child is taking. It will give you insight into what kind of condition this child is having. Then prior interventions. What have they done elsewhere? Has he received any form of physiotherapy? What have they done to him? How far have they gone? What are the likely areas where you are going to step in? But this is very, very important. Apart from prenatal, natal, and postnatal history, reasons for referral is very important. Prior interventions might not even be physiotherapy. It may be traditional, what do you call it? Traditional medicine or traditional care received by him, by the child. Therefore, you should all note this thing and know where you start. Because patient education is also part of the treatment. You definitely have to educate the patient where prior interventions are not necessary, or where prior interventions actually have worsened the situation. Just even if it is a health professional that mismanaged, you have to what do you call it, explain to them where the troubles come in and how you are going to help it, such that they will not at the tail end say the therapy is not effective. They should know that this is where the problem starts. Then here we have under fiscal, we are going to fiscal assessment as physiotherapists. And I said, I wouldn't want to go to detail prenatal, natal, postnatal. Remember we said prenatal, there are issues of purchase organisms, toxoplasmosis, rubella, cytomegalovirus. If a woman is very active in antenatal and they sees infection, whatever it is, they are going to deal with it. History of exposure to all these radiations, everything. Therefore, you ask those ones. Now I'm moving to physical assessment. The child is before you. What are you really going to assess? The child might have all sorts of conditions. It may be arthritis, it may be this, it may be a neonate. But the most important thing is you are doing general physical assessment. And in this general physical assessment, we see there is what we call general motor assessment. We have to know the stage of cognitive development of the child. We have to know the stage of language development. Because actually, motor assessment is very important. But actually, cognitive and language development, they are key factors that drive what do you call it, development in children. Therefore, now if just take part, I give example. If you meet an adult that has cognitive impairment, you as your therapist, how do you compare the response of this guy to treatment compared to somebody who does not have cognitive impairment, that obeys command, that does everything you ask him to do? That is the same thing with the children. Therefore, if a child is having very poor cognitive development, probably is mentally retarded, poor language development, most of the physiotherapy managements you do are likely going to be passive and then probably semi-active, where you know how to stimulate the child to produce the necessary movement. Okay, we now move to the next slide. Then we now have general motor assessment. Under this general motor assessment, we as physiotherapists supposed to assess the following. We have assessment of primitive reflexes. And then primitive reflex is not for all type of children, all conditions. We said especially for children with the delayed milestone and CP. If you are querying delayed milestone, and probably that is what brought the child to the hospital, delayed milestone. The child is already 1 year, but the child does not have head control or neck control. The child is already 8 months, does not see it. All these guys, you now say, okay, let's assess for primitive reflexes. Let's assess and see whether we have obligate reflexes that are supposed not to go, and they're supposed to go and they refuse not to go. Therefore, they are preventing the child from achieving the next milestone. Then we have to also assess the gross motor skill. We record the age at which they occur: head control, rolling, sitting. Yes, some children, like those with Duchenne muscular dystrophy, may not walk until 18 months of age. Some of them past 2 years. Therefore, you now record the age at which they walk. Like some children with Down syndrome, they may not be able to even reach walking status until after 3 years. Therefore, some of them, you now have to note that this is the time they start walking. Then you now have to educate the mother. This is the exact time, like 13 months, where the child is supposed to stand on its own and begin to take a step. In some, 12 months. Therefore, those ones are very important. Knowing what do you call it, the normal developmental milestone, so that we should be able to what do you call it, spot any form of developmental delay. Then we should also assess fine motor skills, and fine motor skill actually has to do with dexterity, whether the child can be able to pick something with the hand, probably be able to write. It depends on the age of the child and everything. Then the next is we are used to range of motion assessment. Therefore, nearly all of us as physiotherapists, when the child comes, we do range of motion assessment of all the joints to see whether part of the range of motion assessment we can use it in the process. We can get whether the child is hypotonia or hypertonia, having hypotonia or hypertonia. We use it to check whether there is what do you call it, a stiffness or contracture, whether there is what you call core contraction, like in children with CP. It's not rigidity, we call it core contraction. Therefore, those ones are also important. Then we now talk about voluntary or volitional and involuntary movement. Voluntary movement, where the child can stretch to pick something, that is volitional movement. Or involuntary in dyskinesia, where you have involuntary movement. A child, you keep a child on the treatment couch, but his hands are moving like snake. These ones are involuntary movement. It begins to tell you that there is central nervous system affectation. Probably this is what you call it, this kinetic type of CP, where either athesosis, choreathesis. When you generally assess, say, okay, it gives you insight, it gives you direction. Then pattern, yes, it depends on the child. Does the child limp? If there is limping, probably there is antalgic gait. Probably, what do you call it? Probably we are going to discuss Lepati's disease. Probably the child is having the skin muscular dystrophy. Probably the child is having what do you call it? Pain in the leg. Probably toe walking. We may have idiopathic toe walking. We may have toe walking as a result of what do you call it? The muscular dystrophy. You can have toe walking as a result of what do you call it? Gastrocnemius or soleus spasticity. We can have toe walking as a result of what do you call it? Pes equinox. Children with hemiplegic CP, some of them, they may do toe walking, is what we call what do you call it? Pes equinox. You may have children with high stepping gait, like those with what do you call it? Injection palsy. Therefore, all these ones are example of what we should assess. The gait. The gait can give us information as to what is actually happening. Then we have coordination. Probably you ask the child that probably does not have coordination, probably to do heel to toe walk, check for run backside, for all these guys, if there are cerebellar issues. Then we should also assess pain and discomfort. Yes. Is it one Baker Faces scale you want to use? But the most important thing is if you manipulate the child's leg, probably gentle passive movement, the child is crying, grimacing, you should know that this child is having some pain. Pain management should be part of your treatment. Pain assessment and management should be part of your treatment. Then you should be able to classify the child functionally based on their ability level. Example, we use gross motor function classification system, GMFCS. Yes, just like the way we used to say. Actually, in pediatrics, we don't use to say gross muscle power 4 and 5 like in orthopedics. Generally, in pediatrics, we say the child is having a gross GMFCS level 1, meaning that it's very functional. Level 2 is functional but requires some little help. Level 3 is functional that he needs some what do you call it, assistance using walking aids like walking stick, like a walking frame, like rollator. This is 3. Therefore, we should be able to classify the child GMFCS 1 to 5, which is very, very important. When you are referring patient or somebody has been referring patient to you and he said, I'm sending you a child with GMFCS 3, you know that the child is ambulant. If it is GMFCS 4 and 5, you know the child is not ambulant. Okay? Then we have assessment of reflexes. Here, actually, I really don't want this presentation to take long. That is why I did not give detailed assessment of reflexes, and because we are not really actually looking at cerebral palsy in this presentation, but at a glance, one can easily assess motor reflex. We call it statutory reflex, where the child is, you can keep the child horizontal on your laps. You just release the head a little bit to go below. Then the child will raise all the arms and the leg and then come as if he's embracing somebody. Motor reflex supposed to go after 4 or 5 months of age. If it does not go, then it's a sign that primitive reflex is still obligate, meaning that the brain is damaged. meaning that physiotherapy that involves more especially neurodevelopmental therapy is required for this child to be able to achieve milestone. Asymmetric tonic neck reflex, symmetric tonic neck reflex, tonic labyrinthine reflex, and parachute reflex. Therefore, we should go. This seminar will not revise everything. I think last year we did it. For those that have attended, I have explained all these guys. Parachute reflex is an obligate reflex. It comes and it remains with you. Like, for example, balance and equilibrium reaction, they come and remain with you. Okay? Therefore, they are very, very important. We should be able to assess reflexes in this child. Therefore, we have reflexes that actually emerge, like parachute reflex emerge after 6 months and it remains with us. Balance and equilibrium reaction emerge and they remain with us. But other reflexes would have to go. Then we now move to developmental motor development in the first 12 months. And as I said, for you to be able to spot that this child is having delayed milestone, most especially those with either pediatric head injury, either what do you call it, CP, or either delayed milestone due to what do you call it, neurogenetic disorders like Down syndrome. This is very, very important. We should be able to say this is a normal developmental milestone, and then we should be able to explain to parents, and it should be able to guide us in our treatment. Like when we talk about motor development from birth to 12 months, at the peak is 12 months, where the child should be able to walk independently. But some children will walk in the 13th or 14th month, but it's still normal. Some children may walk until 15 months, it's still normal. But any child that was unable to walk until 18 months or more, then he has serious delayed milestone. We should note this. Sitting should occur in the 6 months. But actually, if the child is unable to sit, up to 8 months is still within normal limit. But if child is unable to sit until 10 or 12 months, that is a serious delay. By the end of 2 years, please, there are literatures that says by the end of 2 years, any child that is unable to sit by the end of 2 years is one of the prognosis for ambulation. That if by the end of 2 years the child is able to sit, then there is good prognosis he is going to ambulate. But past 2 years, the child is unable to sit. Ambulation, independent ambulation, not holding anything, is likely going to be difficult for the child. Those ones, there are literatures that are, what do you call it, concerning that one. But ambulation will take place only that probably independent ambulation may be a bit difficult. Then holding onto something to stand occur usually at the age of 8 months. But if it does not occur, at least symmetric crawling should be able to take place at the age of what? 8 months. The child should be able to crawl at the age of 8 months. But if it is a little bit delayed, at the age of 10 months or so, the child should be able to crawl very well, hold on to something to stand. But if it is very delayed, past 1 year, then there is delayed milestone. Therefore, this is very important. I really didn't intend to follow it one by one. We as therapists, we should be conversant with this. The next is motor development from 13 months to 5 years. Then by 13 months, every child is supposed to have started walking. But we still remain saying that there may be delays up to 15 months. By the end of 18 months, the child should be able to walk. If not, there is serious delayed milestone. Then by the time the child is 18 months, they say the child should be able to kneel up without support and squat to play, meaning that the child has already passed the age of walking. The child has become so conversant with walking that the child can kneel and squat and come up from squatting. The child can hold onto something like a ball and then stand with it. That is 18 months. Between 18 to 30 months, holding onto a rail, probably putting both the legs, not alternatively, one leg, putting all the legs together on each staircase, then it's part of a good milestone. By the time the child is up to 3 years of age, you should supposed to jump up bottom step. It may not be up bottom step, probably ask the child to jump, the child should be able to jump. Stand momentarily on one leg. They are part of the milestone we look at. Then by the time the child is 5 years, they should be able to jump over a knee-high cut together. Probably you now put something like something that is up to his knee, in the height of his knee, the child should be able to jump. But the most important thing here is, for us physiotherapists, whether the child has learned to hop, run, or anything, the most important thing is that the child should be able to walk. Walking is the basic, functional mobility that is required. Others can come later with treatment. Walking is very important as far as physiotherapy is concerned. Then the next thing is gross motor function classification system. We said remember I said for us in physiotherapy, we should also, apart from using gross muscle power grading, please, in pediatric, we use gross motor function classification system. It's widely used, widely accepted. It's a way, just like the way you use Oxford muscle power grading, is what you use to tell the mobility status of the child. Is he GMFCS 1? Is he GMFCS 2? Is he GMFCS 3, 4, and 5? Therefore, 1 is the highest level of functioning and 5 is the least level of functioning. One can walk without support. The 5th one is actually being backed by the mother. He does not even have head control. Therefore, for GMFCS, we say it's a 5-level classification that describes the gross motor function of children based on self-initiated movement with particular emphasis on sitting, walking with and without walking aid, wheel mobility, and total dependence. Therefore, the next slide is that of the classification of GMFCS. But one thing here is, this is a rough estimate of GMFCS level. Because when we say the child does not have independent mobility, he does not move, meaning that 4 and 5, he uses powered wheelchair or he cannot move on his own or lack head control. But 1, 2, and 3 actually can move, either on their own or with the help of something. Then somebody will say, okay, if a child is at the age of 6 months and he can only, age of 8 months, and he can only sit, how do we classify him? Please, for children that are within the age of 0 to 2 years, the classification is a little bit different from this one. But this one is the age of 4 years up to 18 years. Therefore, for children that whose highest level of function can be sitting can be described as GMFCS 1 if the child's highest level of function should be sitting, like for those that are up to 6 months of age. Therefore, the issue is gross motor classification 0 to 2 years is a little bit different for this one. But this one is universally accepted. 1 to 3, they are ambulant. 4 to 5, they are not ambulant. Okay, we said 1 has near normal gross motor function system, can climb stairs, can walk outside. The highest level of functioning, like jumping, running, and everything, is what is actually giving this child a little bit difficulty. Then 2 works independently but has limitation in running and jumping. But this one, what we are saying here is the major difference between the first one and the second one is that this one can work only within the house. The one in the second category usually function within the house. The other one can function outside the house. The other one can climb stairs without holding onto handrail. But the second one, that's GMFCS 2, will have to hold onto handrails. Therefore, that is the difference. Then the third one uses assistive devices. He can wheel his wheelchair on his own. He can walk using crutches or walking frame or anything. He can hold onto the wall and walk severally. Those ones are GMFCS 3. Then 4 has ability to stand, but he need he need not manual wheelchair. He needs he needs powered wheelchair for mobility. Mostly they use powered wheelchair for mobility. And the last one is, please, not manual wheelchair. They use powered wheelchair for mobility. The last one is the least one that has no independent mobility at all. Lacks head control, usually being carried by the mother. That is it. Then after that one, we now look at the stages of cognitive development. How do we assess cognitive? How do we know the stage of cognitive development? Usually in pediatrics, we use the most common one we use. Please, there are other ones that by Gesslen and all these ones, but actually the Piaget stages of cognitive development is what we use to describe the stage of cognitive development in the child. We have 0 to 2 years, we call it sensorimotor stage. Here, somebody will say, why did they call it sensorimotor stage? is because the child actually communicates only with primitive reflexes and sensations. Therefore, the child communicates with only primitive reflexes. They are the sensorimotor stage. Here, the child develops what we call object permanence. Somebody will say, what is object permanence? Yes, the child now begins to understand that holding him in a particular position gives him comfort. Therefore, the mother used to hold him in a particular position. When a stranger holds him in a different position, the child cries. He has become used to holding in a particular position. That is object permanence. That is a measure of cognitive development. The child has started understanding the voice of his mother. When the mother is talking, the child will stop crying. The mother is close. He has started permanenting some objects. When you now put the child, even if the child, if you put hand close to the cheek of the child starts sucking. That is routine reflex. Gradually, the child develops, understanding that anything that comes through close to the mouth is meant for it to suck. Therefore, object permanence is part of the, cognitive development in a child. Because a child that has no object permanence, whether the mother or stranger takes him, he does not care. Some of these child don't even recognize their mothers because of severity of motor affectation. Then we have pre-operational stage. Then what do we mean by pre-operational stage? By when we say operation, we mean higher brain function. That is higher brain function. The child is walking, but actually, when we say pre-operation, does not actually view world the way the child is supposed to, the way everybody sees the world. The child does not see the world from your own angle. He sees the world from his own angle. We said in pre-operational stage, the child is egocentric. Therefore, when you now, let me give you an example. When you take a small bottle filled with water and the bottle is taller, and you now take a very big bottle, but it's shorter, but actually is wider, and you said which one is bigger, the child will say the other one, the taller one that is actually of a small volume, because he does not differentiate. He cannot see. He does not understand conservation. When a child is doing activity, and you ask him, this is going to injure you, the child is looking at the activity, the fun, not the injury, because he does not see, he does not discern that what you are telling him is actually an injury. You cause injury to him. When the child is coming for treatment and the child does not concentrate, and you said, concentrate, this is going to help you, the child does not understand that this is going to help him because he does not see the world from your own angle. He sees the world from his own angle. He takes only things that actually, in the aspect of things that actually are of interest to him. He does not discern good or bad. That is egocentrism. Let me give you another example of egocentrism. When you take a biro, the biro has the other side. The where you used to write is sharp and is pointed. The other side of it is blunt. And when you show the child the side that is pointed, and you said, how do you think that this side will be? He will tell you it's also pointed because he sees the child, the wall from his own angle. He sees it that this is pointed, the other side should also be pointed. That is pre-operational stage. Then we have concrete operational stage. Therefore, in concrete operational stage, the child begins to understand the point of view of other people. That is where you now begin to see from in pre-operational stage. At times, I used to ask myself, why is it that during our time, our parents will not take us to school? Even they took me to school, by then I was 6 years. They said I should come back after 1 year. By the time you are 7 years, that is where you have concrete operation. That is where you now begin to understand. You appreciate the views of other people. You appreciate the reason why you are not to come late to school. You appreciate the reason why 1 + 1 is equal to 2. You appreciate the reason why you should not pour away the food given to you by your mother. You now begin to understand, the child begins to understand other people's point of view. That is where they begin to understand concrete operation. They now begin to understand that this bag is big. This is more beautiful than the other one. Then I take it. That is concrete operations. Then we have formal operational stage. They now begin to understand things that are abstract. You tell him that God exists. That is when he will now begin to understand. By the time the child is ready to go to secondary school, you now understand that, okay, there is somebody called God and he exists. Yes, you now begin to teach him that something called hypothesis exists. Something called 2 plus 2 but equal to 5 exists. You say, okay, what does it mean? We have it in economics, 2 plus 2 equal to 5. This is very, very important. This is what we call formal operations. When somebody is going to secondary school, and you now ask him that, okay, x plus y equal to z, find x and y. That is deductive reasoning. That is when the child begins to do formal operation. Then when you have a child before you and he is 7 years old and he only interact with reflexes, that means he is still on sensorimotor stage, meaning that the child is having, what do you call it, either moderate to severe cognitive impairment. Then we now have development of our cognitive skill. Let's marry what we have here in this table in Jean Piaget's theory of cognitive development and what we have in our development of cognitive skill from 4 months to 6 years. Look at it. In 4 months, they said the child brings object to mouth for inspection. So I'm conducting seminar on way. Sir, hello, sir. Alaikum salam. Okay, please, there is a little bit of distraction on my phone. Sorry. We said development of cognitive skill. You have it in this table. This is the age at which from birth to 6 years, where cognitive, skills are developed. For those normal cognitive skills are developed. We now said at the age of 4 months, the child brings hands to the mouth for exploration. Everything you give the child, he takes in the mouth. 7 parts mirror. But one thing that is important. Look at the age of 6 years. The age of 6 years, the child is now beginning to do what you call concrete operations. He understands rules and what? Regulation. The mother says don't do it. He understands what the mother means. But when the child is less than those words, when the child is in pre-operational stage, he does not understand rules and regulation. Whether you did it several times, you beat the child, he still does it because he does not understand concretely. He is too egocentric. He is being taken by what he likes to do, not by the rules and regulation. Look at it. Therefore, please, you explore. Therefore, you can always marry what you have in the cognitive development skills and the Piaget theory. Okay. Then we now have language development. Yes, they said language development is a skill and it is considered an indicator of overall cognitive impairment. Yes, if I can give you this example, like for example, in your class, and they said somebody actually can talk very well and he can reason, he can always convince people. Some people will say, Kai, this guy is the most intelligent person. He knows how to convince people. That is part of an indicator. Good language is part of an indicator of what? Cognitive development. Some are good skilled talkers. Some, but actually they said intelligence actually come in different forms. Some people are not good talkers, but they are very intelligent. Some their intelligence actually comes with the ability to talk and reason. Therefore, language development is part of cognitive development. And then here in this table, I have arranged from 1 month to 5 years the cognitive development skills. But the most important, look at 5 years, the child has fluent speech. 4 to 5 years, look just like the motor development. Look at it, 4 to 5 years, go back to the motor development stages. Look at it, at 5 years, he can act stories. Look at in language development, in 45 years, they can act stories, meaning that both motor and language development almost go hand in hand. Where the child does not talk, where the child does not talk, and where the child cognitively acts like a younger child, then he is likely mentally retarded. Then we now have, look at around 18 months, the child should be able to have 20 recognizable words. You should be able to speak 20 recognizable words in your language. But by the time the child actually is 2 years, he can join on nursery rhymes, meaning that if you sing some nursery rhymes, the child should be able to follow you up. By the time he's 45 years, he is okay. He can act stories. He can give you some stories of what happened. By 5 years, he's very fluent in speech. Okay, what we are saying here is about the issue of knowing normal developmental milestone in language, in motor and cognitive, such that when a child is having delay, we can easily say, okay, this having is delayed, having delayed language development, delayed cognitive development, or delayed motor milestone. Then they said language development, physiotherapists classify language function using communication function classification scale. Okay, yes, just like we have the gross motor function system classification system, gross motor function classification system, there is also what you call communication function classification system. Communication function classification system. It is just like the gross motor function classification system being an ordinary scoring of 1 to 5. 1 is the highest level of function, 5 is the least. Just like gross motor function, 1 is the highest level of function, 50 is the least. 1 being the highest level of communication. Then they said here in communication function classification system, I want us to go and check. We can have speech. The child can talk. Some of the children cannot talk, but they can gesture using hand. Which one do you like? He can use it. Probably the child does not develop speech, but he can easily gesture using the hand. Then behaviors. Some of what the child does. You ask the child, can you bring this thing to me? The child brings it. He knows what you are saying, but he actually cannot talk. Some children are like that. They may have delayed communication skill, but they can respond to command. We have eye gazing. The child, when you talk, the child, from the way he gazes, you know, then some facial expression, and we can have alternative communication system. Those ones are used in the formation of communication ability classification system. Then we have level 1. We have effective sender and receiver with familiar and unfamiliar partners. Somebody who can actually communicate with unfamiliar people, can communicate with father, can communicate with the therapist. He is a sender. He can talk to you, and when you talk to him, he can respond. He is a receiver. He responds to command, and he can also talk. That is 1. Effective but slow sender with familiar and unfamiliar. Look at it. Effective but slow what? Sender. He like send. He can talk. He can gesture with you, the therapist, and the mother, but actually he does not obey command compared to the other one. Obeying command, somebody who obeys your command and talk or respond to you is better than somebody who only talk, but the obeying command or talking back actually is less. That is a slow sender. But then we now have effective sender and receiver with only familiar partners. What we mean, somebody who can only communicate with the parents only or the caregiver, but communicating with others that are not familiar, or sending what do you call it? What do you call it? Uh, 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 what do you call it? It's just a sender and receiver, but only with familiar people. With non-familiar people, by the he has problem. Then he is level 3. Then we now have level 4, inconsistent sender or receiver with familiar, even with the mother. The mother will tell you that actually I do understand some of the things he says. I do understand. He do also respond to some of the things I said, but actually not always. That is 4. Then we now have seldom receive, or what do you call it? Seldom effective
For
sender
you,
or receiver.
lecturer now.
Hello? Hello? Hello?
Please
Hello?
continue. Continue.
Okay. The last one we say seldom. The child does not effectively, what do you call it? Or seldom, we say rarely. Does the mother tell you that the child responds to her command, or the child talk to her, or the child gesture, or the child in any form of communication, really, then he is at the level 5. Therefore, but actually we in physiotherapy, we only use GMFCS, but communication classification system is, we can also use it to what do you call it, to assess communication ability of the children. Then we have part 2, measurements in pediatric physiotherapy. When we said measurements, we mean assessments, but we said assessments that are valid and reliable. Okay. Here, by the way of introduction, we say physiotherapy should select and use outcome measures appropriate to the patient that are of high quality and are based on ICF model. Yes. Here, there are 2 things. We said appropriate to the patient, meaning that if the child is having Down syndrome and I want to measure a construct in Down syndrome, I shouldn't use a questionnaire that is validated or an instrument that is validated for all, to use only for a child with CP. Or a child is having rheumatoid arthritis, and I should use rheumatoid arthritis specific instruments on him, not that of a child with what do you call it, Erb's palsy. Therefore, they said it should be appropriate, and then should be of high quality, meaning that it should be valid, it should be reliable, and it should be able to assess response to change. When you as a therapist did a particular, what do you call it, administer a particular treatment, you should be able to see change when you use it. Like if you use peak flow meter, you use everything, and if there is change in vital capacity, that thing should be able to tell you that there is an improvement. Yes, that is a high quality one. Then we said based on ICF. Yes, based on ICF 2001 model, we classify what do you call it, participants cases based on either they are having impairment or they are having disability related issues or they are having participated related issues. Then when we are assessing impairment, we know we are assessing impairment, then we use impairment outcomes to assess impairment. When the major problem of the child is that of participation, then we use participation related instruments. Then when we are assessing disability, or what we call activity participation, then we should use participation activity, what do you call it, related outcome measures, because they are more relevant to the patient. When you want to assess, you as physiotherapist, you want to assess ability of the child to climb stairs. That is activity. Then we should use an outcome measure that encompasses what do you call it, staircase climbing, to show that the child has improved. Then we have attribute of high quality instrument. We talk about reliability. A reliable measure gives results that are reproducible and what do you call it, and consistent. For example, if I come to the clinic, if a child comes to the clinic and I use a measuring a weighing scale, and the weighing scale gives me the weight of the child is 7 kg, and if I measure it again, it gives me the weight of the child is 7.5 kg. I measure it again, it gives me 7.3 kg. That means the weighing scale is not reliable. It does not give measurements that are consistent. But let me give you an example of validity. Let me give you a measuring instrument may not be reliable, but one can actually correct the measurement error if it is just reliability. Let me give you an example of measurement. You measured using a weighing scale. The child's weight is 7 kg. And you use a bathroom weighing scale. Probably a standard weighing scale in the clinic gives 7 kg. And a bathroom weighing scale in your clinic gives you 6.5 kg. You keep measuring it, it gives you 6.5 kg. But another standard weighing scale gives 7 kg, meaning that your weighing scale is having an error of 0.5 kg. Therefore, whoever comes and you measure his weight, then you have to add 5 kg. It is possible somebody of weight 60 kg comes in and you use your binomial scale, it gives 55. Then when you use the standard weight scale, it gives 60, meaning that you have to add 5 kg. Meaning that something that is not reliable, if you know the error, you can correct it. Validity is one of the biggest problems we have. Validity is the extent to which a measure records or assesses what it's supposed to assess. Let me give you an example. If you are assessing, let's say, if you are assessing gross motor function, and you said, okay, I want to assess gross motor function in this child, and somebody said, actually, since it's gross motor function, you can use Oxford muscle power gradient to assess gross motor function. And when you see the assessment, they are not assessing the same thing. This guy is assessing muscle power. The other one is assessing mobility, level of mobility function, physical dependence. They are not assessing the same thing. Therefore, you cannot use them interchangeably. That is validity. It's supposed to measure the something it measures. Just like you said, you want to use pain assessment measure as a measure of quality of life. Therefore, when you use pain assessment measure, for example, lava devas, you now said, okay, the person that has high VAS, probably pain of 8, is having lower quality of life. So person having 0 pain is having higher quality of life. It does not work that way. The instrument you are measuring must measure what it's supposed to measure. That is validity. Then sensitivity, the extent to which the measure detects a disorder when it is truly present. Therefore, it has to be sensitive. When you measure, like for example, when you want to measure, let's say, can I say, how do we put this thing? Like somebody want to measure chest expansion. When you measure chest expansion, you can use after in deep breathing, you can use what do you call it, a measuring tape. You can say, okay, reliably, the chest has expanded from so to so. That is chest expansion. Then you cannot use the same what do you call it, chest expansion using measuring tape and said what do you call it, you want to let's say assess deformity in the chest. Or let me give you this. We give example of peak flow meter for people that use it to assess vital capacity. And then after you must have assessed vital capacity, and then after some sessions of treatment, you administer the self-peak flow meter and you see improvement. Then that peak flow meter is actually responsive to change. And another thing is that if that particular individual comes with evidence of dyspnea, comes with evidence of reduction in vital capacity, and then you measure it using peak flow meter and it shows you, yes, there is reduction in vital capacity less than 1,200 mils. You now said, yes, it is actually working. Just like say you want to measure, let me take another instrument. Let's take another instrument. Okay, let me give you an example of a weighing scale. Let me give you an example with weighing scale this time around. Like for example, somebody comes with obesity. He is having a weight that is up to, let's say, 30, what do you call it? Let's say 100 kg. And your weighing scale is telling you that this guy is having, let's say 80 kilogram. Or when somebody is coming with cachexia after an illness or a cancer or anything, and then by the time you see this guy is having, let's say, the weight supposed to be less than 18 kg, and it shows you 20 kg. It's valid. It's not valid, and it is insensitive because it cannot detect a disorder. Probably before we finish, I can get a good example for sensitivity. But actually, when an illness is present, you use a particular measure, it's supposed to show you that that illness is present. If it tells you that illness is not present, then it's not sensitive. Then sensitivity also can come as a result of reliability. When there is improvement, it's supposed to show you improvement. It can detect illness if it is present, and it can detect improvement if there is improvement. That is what it means by sensitivity. Please hope you get it. Okay, the next is we have outcome measures. Like, for example, we have impairment measures. The first impairment measure is persisting. Spasticity. If you are measuring spasticity, modified Ashworth scale, modified Tadeusz scale. Therefore, they said modified Tadeusz scale is more sensitive to measuring spasticity compared to modified Ashworth scale. Then we have balance. Time up and go test is sensitive in assessing balance when there is loss of balance. Or we have pediatric balance scale, we have functional reach test. They are all sensitive in assessing balance. Then we have range of motion, universal goniometer is also sensitive. When there is reduction in range of motion, you use goniometer, it's supposed to tell you that there is reduction in range of motion. Those ones are sensitive. If there is anything in reduction in range of motion, it's supposed to show you. Then we have medical research council scale. That we have the Oxford Muscle Power Grading. If there is weakness in when you use medical research council scale, it's supposed to tell you that this guy has weakness. If it does not show, then it's not sensitive. Then that is what it means. Then we have impairment scale continuum. We have pain in infants. We use premature pain, infant pain profile. Like, it has a maximum score of 21. Each item is scored from 0 to 6. The minimal score is no pain, and a score of greater than or equal to 12 mean moderate to severe pain. That's in infants, for those that are in the neonatal area. Then pain in children, you can use one Baker FACES scale if the child is less than 7 years. We are used to seeing the FACES scale. We use one Baker FACES scale if the child is up to less than 7 years or around 7 years. Then we can use FACES leg activity, cry, and consolability behavioral tool, the FLAG. It can be used to assess pain in both normal and cognitively impaired children. We use it in children with CP also. Those with cognitive impairment, you can use it. Then we have pediatric pain profile that has 20 items. Each is scored from 0 to 4 points. And then with scores ranging from 0 to 60, then scores of 14 or more indicate severe pain. Here we are looking at impairment measures. Remember, we said outcome measures in pediatrics can be impairment measures. It can be pain assessment, it can be range of motion assessment. All those ones are impairment measures. Generally, impairment measures have to do with either the structure or function of the body. Those ones are the impairment measures. Look at it in the heading here. Impairment measures assess body structure and what? Function. Then we now move to participation, activity-related measures. Measures of activity like 6-minute walk test. Like, for example, we are used to giving 6-minute walk test as a form of functional test for children with sickle cell disease. It's a moderate test to check functional capacity in children with sickle cell disease. Okay, we have pediatric evaluation of disability inventory. It actually measures more of what the child could not do compared to what the child. Again. Okay. Therefore, we are saying, we're talking about activity-related measures. What the child does for himself, what the child do on its own, what the child does like every other child in form of play, in form of activity, that is activity-related measures. They say performance of a task, action by the child on its own. Therefore, these ones are, we can have activity scale for the kids, pediatric functional independence measure. You know, we have functional independent measure for adults. That is the function for pediatric, we call it WIFIM. Then we now have measures of participation. Here, participation according to ICF means involvement in life situation. We can measure integration into school, fulfillment of age-related roles by the child. Does he help the mother going to somewhere? Does he participate in what do you call it? In play activities like other children? Do they go for something like let's say recreation? Yes, all these ones are very important. We have school function assessment, Junior Athletic Self-Report Index, Canadian Occupational Performance Measure. They may be measures of participation in children. Therefore, we cannot use measures of participation as measure of, let's say, activity. Participation is different from activity. Let me give you an example of participation and activity. If a child actually comes to the class and he cannot see the board because he has impairment of vision, and you provide him with glasses and he is able to see the board, that is activity. If a child is unable to walk and you give him a walking stick, that is activity. The child is unable to walk and you train him and he's able to walk, that is activity. But when the child wants to go for a walk with other children and is unable to walk, that is participation. If the child wants to go for recreation, like with other children, and is unable to go for recreation and play like other children, that is participation. If the child wants to enter the class, and then the class does not have a very good door, lack of accessibility, the child would either stay in the window, peep through the window, or he goes out of the class entirely. That is participation issue. Activity, what you do for yourself is activity. But if one does not involve in life situation, take part in activities that other people do, that is participation. Okay. Then the last one, they are measures of quality of life. We have so many measures of quality of life in pediatrics. We have pediatric quality of life questionnaire. We have so many versions for CP for all these children with the measure of quality of life. So we have cerebral palsy quality of life questionnaire, child health questionnaire. They use child health questionnaire to assess quality of life. Pediatric outcome data collection instrument, policy, they also use it. Kid screen, and we have what we call caregiver priorities and child health index of life with disability, CP child, they use it. All those ones are what do you call it? Measures of quality of life. But remember, we have said it. In pediatrics, we use what do you call it? In physiotherapy, actually, is part of what is required. We use disease-specific instruments. We can use generic instruments. Please, there are two types of instruments. We have what you call generic instruments. What we mean by generic instrument, like WHO quality of life questionnaire, is a generic instrument. Generic instrument meaning that if you want to measure quality of life for whoever you want to measure, no matter the type of condition that individual is having, that is what you call, you can use it. That is generic. But when you say disease specific, like the one we have cerebral palsy quality of life questionnaire, then you should use it solely for children with cerebral palsy. It is better than you use kid screen. Therefore, what we are really saying is disease specific, they are created, those instruments are created for specific, to be used on specific conditions, unless they are validated on other conditions, like the GMFM, like the GMFCS. All these ones are validated on other conditions, not ordinary CP. Okay. Then here we have the detailed description of other instruments. We have the functional independence measure. Look at it under standardization, it has a reliability. The reliability ranges from 0.1 to 1. And then you can see the reliability of 0.9. And they are telling you it is tested in children, what do you call it? 6 months to 8 years with neurodevelopmental disabilities. Meaning that if you want to measure activity in children, in all types of children, because the children with neurodevelopmental disabilities, you can use functional independence measure to measure their functional ability. That is what do you call it? Activity. Then with the other one, we have gross motor function measure. They are used to assess change in gross motor function in children with disabilities. And then the group tested, they are tested in children with CP, Down syndrome, osteogenesis imperfecta, and all children with developmental delay, meaning that gross motor function, and they look at it under clinical utility. They say it's well respected and well used, what do you call it, clinically, meaning that gross motor function measure is a valid and reliable tool to use in assessing the gross motor function of children with several disabilities. Then we now have Canadian occupational measure. Remember we said Canadian occupational measure is a measure of participation. Here, it is being tested in children with disabilities also. Parents is a parents completed form, though it is a very lengthy form. It has a lot of items, almost up to 300 items. Then we have school function measure. Therefore, on this table, we have measures of participation. Here is a measure of participation that is under school function measure. Physiotherapists, occupational therapists, and all others, including teachers that are familiar with the child, will now assess the form. It's a measure of participation in children. Then we now have functional reach. This is a measure of impairment. It's a measure of balance. Group tests, healthy children, what do you call it? Healthy children, children with balance dysfunction, children with lower limb spasticity. It is being tested in these children. Therefore, you can assess it you can use functional reach in healthy children. You can use functional reach in children with physical disability. It is used to measure, what do you call it? Balance in children. Then you now have pediatric evaluation of disability in the inventory. It is being tested in children with physical and cognitive disabilities. And then look at its clinical utility. It is appropriate to investigate. It is clinically appropriate to investigate the amount of assistance a child may require in functional activity and social interaction. The most important thing here is it's like measure more of disability compared to functional independence measure, because what do you call it? It assesses the amount of assistance somebody requires. Measure of more of disability. That is why the name. Okay. Then finally, we said summarily, we have pediatric, what do you call it? Physiotherapy assessment is usually an ongoing process. We cannot assess all children at once. Therefore, we assess a particular construct after the other one. We start to assess, most especially we as physiotherapists, we assess impairment measures, range of motion, muscle strength, all these guys first, before we now move to disability or what you call activity limitation measures, before we now begin to look at participation. They're supposed to come this way. Then the next thing we said, it begins with detailed history taken, followed by physical and outcome measurement. And we said outcome measures in pediatric rehabilitation must be reliable, valid, and sensitive to changes due to care. Therefore, if outcomes are not sensitive to changes due to care, then we will not be able to communicate how effective our treatments are. Okay, we said thank you for listening. This is the end of the first lecture. Thank you. Office. Okay, comments, questions? Ini kepada I boleh dia. Let's say bikin muscular dystrophy. Hello, are you with me? Hello. Hello.
Yes, sir, we are with you.
Okay, questions, comments, or I should go to the
Yes,
next
sir. Thank you
presentation?
very much.
Okay.
We are with you, sir.
Okay. Okay, our next presentation is on Duchenne muscular dystrophy. And let me share the slides. Sorry. Right. Sure. Check it out. Okay, this is, we are going to, what do you call it? This is part of the what do you call it? Neurogenetic conditions. I kept mentioning Down syndrome, but Duchenne muscular dystrophy is another neurogenetic condition that we as physiotherapists, because it's one of the most common, apart from Down syndrome, is also a common neurogenetic condition that we encounter in the clinic. Duchenne muscular dystrophy. We said, okay, let me give an overview. Actually, last year during our presentation, remember we said we categorize genetic conditions or conditions of genetic origin into three. The first one, we say we have chromosomal abnormalities, where we have, what do you call it, either addition or subtraction, or what we used to call deletion, duplication, translocation, do occur in the chromosome. We call it chromosomal abnormalities. Therefore, here we give example of trisomies, all the Down syndrome, Patau, Edward syndrome. We have the Jacob syndrome. We come to talk about what do you call it, aneuploidies, like the what do you call it, the Klinefelter syndrome. We talk about what do you call it, Turner syndrome that affects ladies, women, children. Therefore, those ones are chromosomal abnormalities. And there are ones we call the single gene disorders. Here, the problem is not in the chromosome, but in the gene that is contained in the chromosome. We give example of what do you call it, autosomal dominant, autosomal recessive, X-linked recessive. In autosomal dominant, we have neurofibromatosis, we have osteogenesis imperfecta, we have all these guys. In autosomal recessive, we have sickle cell disease, we have albinism, we have cystic fibrosis, Tay-Sachs disease. And then when you talk about X-linked recessive, here, the issue with X-linked recessive is that for male, the mutation that occurs is actually on the X chromosome. The mutation, remember, we have male children usually have X and X chromosome, X and Y chromosome. Female usually have X and X chromosome. Then, since the condition actually has a predilection to X chromosome, the mutation takes place on X chromosome. If it occur, please, on genes, not X chromosome, on genes on X chromosome, on genes on X chromosome. Therefore, if it occur on the gene on X chromosome, but in boys, then they have the disease. They are no carriers. But if it occur on the gene on X chromosome, but in female, because she has two X chromosomes, then she is a carrier. Therefore, for females, usually they have 50% chance of being carriers. But for male, they have 50% chance of being affected. That is one thing with Duchenne muscular dystrophy. It's an X-linked related disorder, X-linked related disorder, and the mutation that takes place is on the genes on X chromosome, not on the X chromosome itself as a whole, but on the genes on X chromosome. That is what we are saying. And it's actually a progressive, what do you call it, muscle degenerative disease. Therefore, that is the way of introduction. We reflect back on the, what do you call it, on the classification. By way of introduction, we say DMD is a degenerative muscle disease that affects primarily males, but females are usually carriers. It is an S-linked recessive inheritance through a carrier mother or by spontaneous mutation of gene coding for dystrophin protein. Okay, please, where do we call it a carrier mother? Please, 90%. We are not discriminating against women. 90% of the children with what do you call it, with acute muscular dystrophy, or to some extent, if not up to 90%, they inherit the condition from a mother. Because the father actually does not survive to even, what do you call it, marry and give birth to a child. Therefore, it is the carrier mother that actually end up having another child, male child with Duchenne muscular dystrophy. But research has shown that Duchenne muscular dystrophy do happen due to spontaneous mutation, meaning that the mother and the father are normal, but spontaneous mutation will now take place in the child. Yes, that he develops Duchenne muscular dystrophy. And then what are the causes of this spontaneous mutation? That is why it's not easy. We don't allow mothers to go into ionizing radiations like X-rays. Mutation can take place in the child. Mutation can take place in the mother. Therefore, the mother does not have it, the father does not have it, but the child has it. And they are just few percent, but majority are inherited. Okay, the son has 50% of becoming affected, and the daughter has 50% of becoming a carrier. The most common gene mutation is what? Deletion. Therefore, if you can reflect back on what we did last year, there are so many deletions in female Prader-Willi syndrome, deletion in male, and in male Prader-Willi, in female.
So we can't hear you.
So there's no video, no audio.
We have lost communication, sir. What is happening? We lost. There's no more voice or video.
We can hear you, sir.
Is it okay? Hello, can you hear me now? Hello.
Yes, we can.
Yes,
Yes, I
Clearly,
can.
sir.
I
there
can hear
was
you.
little network problem, and we have resolved
Okay.
it.
It's
Okay,
okay. Okay, sir.
We are discussing dystrophy. It is a glycoprotein that is located in the inner surface of the sarcolemma of the muscle fiber. You know, sarcolemma, just like the plasma lemma, is a component of the wall, cell wall of the muscle fiber. Therefore, it maintains the integrity and it provides structural support to the muscle fiber. Therefore, if the gene that encodes for dystrophin is deleted, then the dystrophin will not be formed. Therefore, in these children, the gene that codes for in dystrophin protein is deleted, and the gene and dystrophin is not formed. Therefore, without it, the muscle breaks down, and the person gradually becomes weaker. Then we now move to the incidence. It's an S-linked inheritance. We have 13 to 33 cases per 100,000 live births, meaning that in every 100,000 you find 13 to 33 cases. And then we have new mutations. Remember, we said there are cases where the families they don't have a history of Duchenne muscular dystrophy. We have 1 in 10,000, meaning that in every 10,000 you can have one case of new mutation. Then we have pathological features. Here, remember we said just like a common cell that an animal cell that we know, it has cell membrane. Therefore, due to the absence of dystrophin gene, the cell membrane of the muscle cell will now break. The content of this whole cell will now pour out. When the content of the cell is pour out, there is what we call excess extra calcium that doesn't supposed to even come out. It is within it because it was intracalcium before. Now it has become extracellular calcium in the damaged myofibril will now stimulate relentless necrosis in the neighboring cells. Then the neighboring cells, anyone that the extracellular calcium touches, it will now break. Then it stimulates relentless necrosis. Initially, the muscle fibers will regenerate. As the muscles are regenerating, other cells are dying, muscles will be regenerating. They will keep pace. 10 myofibrils are dead, 10 new myofibrils are formed. That is regeneration keep pace with necrosis. But later, persistent necrosis overrides regeneration, meaning that the rate at which the cells are dying, the muscle cells are dying, the body cannot keep forming the new muscle cells. Therefore, some of the damaged muscle fibers are replaced by connective tissues and fat. Therefore, you see a child with hypertrophy of the calf, hypertrophy of the shoulder. We call it pseudo hypertrophy. It is not a real hypertrophy as a result of exercise or muscle bulk as a result of increase in muscle bulk as a result of increase in the size of the muscle fiber. No, it's as a result of connective tissue and fat that replaces degenerated muscle fibers. Those viable muscle fibers cannot exert full tensile strength. They are intertwined in the full of fibrous tissue. Yes, another factor. That is why we physiotherapists are not encouraged to give strengthening, vigorous strengthening exercise to children with muscular dystrophy, because they have mixture of normal muscle fibers and abnormal normal muscle fibers and fibrous tissue. The fibrous tissue is actually these normal muscle fibers, they are intertwined in the pool of fibrous tissue. Therefore, they cannot exert full tensile strength, meaning that the muscles are going to be weak, and that when you now, and they are very few. When you now ask the child to do strength training, you give him weights to carry, the few viable muscle fibers are likely going to die. Therefore, it's better we do free active rather than resisted active exercise. Okay. Then they said when this full of fibrous tissues are actually pressing on the normal viable muscle fibers, they may lead to disuse atrophy of viable muscle fibers because they cannot exert full force to to bring about motion. Then they talk about clinical features of muscular dystrophy. The diagnosis is around 3 to 5 years when the physical activity levels are observed to fall below those of their peers. Therefore, what we are saying is usually these children may not learn to walk until the 18th month of their life. Some of them will now begin to start walking. But still, by the age of 3 to 5 years, some of the things, all the activities other children can do, these guys cannot do. They cannot run, they cannot hop. What other children are running, hopping, galloping, they cannot do it. They can only manage to walk. Then you now understand that these children are having a true problem. They said there's progressive symmetrical weakness of proximal muscles. Yes, please, they have weakness of proximal muscle, meaning that muscles that are close to the spine. Like for example, look at this picture. These are the proximal muscles that are close to the spine, muscles that are spinal muscles that are of the quadriceps, what do you call it? Muscles of the trunk. They have very weak trunk muscles. They have weak anti-gravity muscles. Okay, let's go back. They have calf pseudo hypertrophy by the age of 5 years. Okay, what brings about this calf pseudo hypertrophy? Let me show you what brings about the calf pseudo hypertrophy. Observe this child with lordotic gait. What do you observe? The child brings all the shoulders back and then pushes the tummy forward. It's a way of trying to compensate, not falling forward. The trunk muscles are weak. The quadriceps muscles are weak. The only way this child can stand against gravity is by walking on the toes. Therefore, the child will walk on the toes in order to prevent falling forward. That's one. And in the process, he overutilizes the toes. Therefore, the calf muscles are always bring to action so that he does not fall forward. Therefore, calf muscles are usually brought to action always. Okay, altogether, the calf muscles are brought to action always, and the child brings the what do you call it, pushes the shoulders and the arms back in order to support so that he does not fall forward. That is what brings about calf and shoulder hypertrophy. He relies on the shoulders that he took backward in order to support the body not falling forward, and the calf muscles, he relies on them so that he does not fall forward. Usually he walks on toes. That is what brings about the calf hypertrophy. Then we have trouble climbing stairs. They find it difficult. For somebody who actually does not walk on flat ground until he pushes the two hands backward, how do you expect that person to climb stairs? They have difficulty jumping and running. But thank God, research has found that for children within the age of 3-4 years, if they start a corticosteroid therapy on time, these guys are likely going to be able to climb stairs and do other activities. Probably, what do you call it? Disability will be pushed backward to later years. Then we have Gowa's maneuver when rising from the floor. Okay, let me show you Gowa's maneuver. This is Gowa's maneuver. Look at 1. Can you see 1? When the child wants to stand up, this is 1. The first one that is just directly above the Gowa's what you call writing. This is 1. Then we have 2. We have 3. The child will have to hold onto his body. Why is the child holding onto his body? Because the muscles, the extensors of the back are weak. The proximal muscles are extensors of the back are weak. The quadriceps are weak. he has to rely on the hands to support the body to stand him. That is Gowa's maneuver. Okay. Then the child walks with waddling gaits. He walks like a duck, D-U-C-K, waddling gait, with wide base of support in order to get balance. He do toe walking. I said the reason for toe walking is not that it's not in order not to fall forward. That brings about the hyperactivity of the calf muscles, and the child can fall frequently. Okay. Then we now move to clinical features of Duchenne muscular dystrophy continues. The natural history presents relentless progressive deterioration of limb and trunk strength, alongside contractures and scoliosis. Actually, contractures in this guy are very common in 4 areas. Area number 1 is TA tightness. TA, because the child is usually, walking on toes, there is TA tightness. We have tightness of iliotibial band. And then, because the child actually does not have, strong quadriceps muscle, he tends to have, tightness of the hip flexors. And to some extent, tightness of knee flexors and extensors. Then, remember we said walking is delayed up to 18 months of age. And then this child, actually, most of the children, by the time they reach 12 years, they are unable to walk again. And then inability to walk signal the beginning of having respiratory compromise. When they are unable to walk, they are lying on the bed always. They are unable to walk, or they are sitting on wheelchair always. That predisposes them to having scoliosis. And another factor causing scoliosis is weakness of the muscles of the back. Remember, we have paraspinal muscles. These longitudinal, semispinalis. All these muscles are helping to strengthen, they provide support to the vertebra at the back. What happens if these guys are weak? Then scoliosis sets in also. Okay, then finally, we have cardiac and respiratory function deteriorate later. Somebody will say, why respiratory muscles? Respiratory muscles become weak as the child becomes wheelchair bound. Then for cardiac muscle, we have dystrophin is also present in Purkinje cells. Purkinje cells are the cells actually that helps to conduct that helps to send nerve signal throughout the nerve conduction fibers in the heart. Dystrophin isotopes tends to become present in the heart. Then it now gives somebody predisposed to heart problems, especially heart failure. Then we now have respiratory involvement, significant fall in vital capacity due to loss of ambulation, meaning that part of the main aim of physiotherapy is to keep these children working for as long as possible. We know the natural history of the condition is that of becoming wheelchair bound by the age of 12 or 13 years. Then how do physiotherapists now prevent these children from becoming wheelchair bound? Remember, we improve their respiratory and muscle function because it's actually delayed. It reduces the rate of muscle deterioration. Physiotherapists also help by improving their working ability. They maintain working for as long as possible. That is the only way you can improve respiratory function. Progressive weakness of respiratory musculature causes ventilatory limit secretion. Usually, when a child has impaired cough, he may need suctioning. They said patient may suffer from lung collapse, atelectasis, hypoventilation, pneumonia, chronic alveoli. Pneumonia means chest, infection and ventilatory failure. Then we have respiratory involvement continues. They said the vital capacity plateaus between 1,100 and 2,800 mil between 10 and 15 years of age. The vital capacity can be lost at the rates of 200 to 250 per year, meaning that when the child is wheelchair bound, no more working on his leg, and nothing is being taken, the vital capacity is lost 200 to 250 mil per year. By the time the child reaches 10 years, he must have lost 2,500 mil. That means that is likely going to lead to respiratory failure. Then cardiac involvement. The dystrophin isotopes are also evident in the membrane surfaces of the cardiac Purkinje fibers. They are thought to distribute cardiac conduction problems. They contribute to cardiac conduction problems seen in DMD. They said DMD is often associated with enlargement of heart, persistent tachycardia, and myocardial failure. And then you know the reason for what you call it, persistent tachycardia, because of what? Conduction abnormalities due to the affectation of the Purkinje fibers. Cardiac involvement is present in almost 60% of the children with Duchenne muscular dystrophy. Therefore, okay, let's continue. Then lab evaluation. For all children with what do you call it? For all children with Duchenne muscular dystrophy, serum creatinine kinase level are elevated more than 10 times higher than normal range. Therefore, this is one of the definite diagnoses. When serum creatinine kinase is greater than 10,000 milliunits per mil, then it's one of the assessment. The fourth bullet point, almost 100% of the patient with DMD, there is complete absence of dystrophin from muscle biopsy. It's another factor. Then we have DNA analysis. If they did DNA analysis and they found that it's normal, diagnosis must be confirmed by protein analysis or immune histology test. What they are meaning here is that when they do DNA analysis and they could not find the gene that is mutated, another thing they should do is check muscle biopsy so that they can see whether the dystrophin gene is present or the dystrophin gene is absent, and they can check creatinine kinase. Then physical assessment. What do we assess as therapists? Common is going to observe capacity. Then a child comes, when you ask the child to walk, he's going to walk on toes. The second thing, you assess functional capacity. They fatigue easily. Why do they fatigue easily? One, reduction in functional capacity due to reduction in what do you call it, vital capacity. The other one is the muscles fatigue easily because what the child is having, muscles are very few, therefore they fatigue easily. Then we have assistive and we assess, example, wheelchair at the age of 12 years if the child can no longer walk, or we give manual wheelchair. We give manual wheelchair if the child can propel manual wheelchair. Where the child cannot propel manual wheelchair due to weakness of the hands, then yes, he can be given power wheelchair. Then we should also assess the need for night or resting splits. Please, this is very, very important. In Duchenne muscular dystrophy, resting splits are very important in the night, most especially to stretch the calf muscles. To stretch calf muscles such that the permanent contracture did not take place. Then they can use rollator walkers. You can assess the need for rollator walkers. Therefore, you can have walking frame that have tires, such that you can encourage them to stay as long as possible walking. Then in our physical assessment, we also assess for gaits. But actually, these guys probably more of research. But actually, is better we assess for trunk sway, because actually the hands are usually clasped behind, therefore they may have a sway of the trunk. Their muscle performance, we can assess muscle power using what do you call it, Oxford muscle power grading. We can assess for posture, most especially scoliosis. Scoliosis is found in all children with Duchenne muscular dystrophy because of weakness of the trunk musculature. It said it is also associated with lordosis. And remember, we said the cause of lordosis is because the shoulders are being put backward and the tummy is being put forward in order not for the child to fall forward because of weakness of the trunk muscles. Then range of motion assessment. We have to assess all the range of motion of what you call it, joints in the leg. But specific attention must be given to the hip, knee, the thigh and iliotibial band. Then ventilation. We talk about all these peak flow-meters and all these guys. We have to assess chest expansion, strength of the curve, and measure the vital capacity. Then musculoskeletal pain. They said musculoskeletal pain must be taken seriously because of what? The mainstay of the treatment of Duchenne muscular dystrophy are two: corticosteroid therapy and physiotherapy. But corticosteroid therapy has actually a lot of complications associated with it. It leads to osteoporosis in these guys. Therefore, it reduces bone density, it reduces immunity. Therefore, it reduces both bone density and predisposed to fracture. What we are really saying here is that when a child with Duchenne muscular dystrophy complains about musculoskeletal pain, there is need for you to ask them to do X-ray, because of this corticosteroid therapy is taken is likely going to have leads to brittleness of the bone and fracture. Then we have the functional rating scale for the Duchenne muscular dystrophy. Please, this is where we are saying, if I use now, if I use GMFM or GMFCS to assess the function or to rate the function of a child with Duchenne muscular dystrophy is invalid, because they have a disease-specific instrument called Vignos Functional Rating Scale for Duchenne muscular dystrophy. Therefore, it's meant for you as your therapist, walks and climbs stairs without assistance, walks and climbs stairs with the aid of a railing, walk and climb stairs slowly with the aid of railing, walks but cannot climb stairs, walk assisted but cannot climb stairs and get out of stairs, walks. All this one, if you read, they are self-explanatory. They are meant to assess the functional level of what a child will grow, Duchenne muscular dystrophy. The next is medical treatment. Corticosteroid therapy. You either use prescribed prednisolone or deflexacort. They slow the progression of DMD. They slow the progression of muscle damage. Therefore, oral steroids have shown that some promising improvement in motor skills such as running, jumping, and children that are within the age of 3 to 5 years. It says steroid hormone improves vital capacity and cardiac function. But however, they have side effects. The side effects of the steroid, we said, include weight gain, osteoporosis, high blood pressure, behavioral problem, acne in children, reduced growth, and delayed puberty. Puberty. Then we can have gene therapy to restore dystrophy in the cardiac muscles. Then the next is physiotherapy treatment. The aim of physiotherapy is to prevent joint contractures. We talk about this, to slow down the rate of muscle weakness, to prevent spinal deformities. Therefore, we keep the child standing for as long as possible. We keep him standing without him becoming wheelchair bound or bed bound. He's not likely going to get deformity. We keep the patients on their feet for as long as possible to maintain good respiratory function for as long as possible and to maintain the overall health and function of the child. Then we now have the treatment principle, involves using active and passive stretching. And they said appropriate stretching of Achilles tendon, iliotibial band, knee and hip extensors and flexors on regular basis may delay the onset of contractions. The second one, we talk about regular stretching. Hello? Okay, we have appropriate, we talk about regular stretching exercise should be incorporated in daily routines. Example, self-stretching using the wall. Because the calf muscle is usually, in shorting position, you can ask the child to sit down with their leg touching the wall, such that the heel will not be touching the wall. Another one is assisted squatting. You ask the child, you hold the two arms of the child and the child do assisted squatting. It helps to stretch the leg. You ask also the child to lie down prone. Then as the child lie down prone, you can stretch the hip flexors. Then use of night splint to slow progression of ankle contractures. You can use rigid ankle ankle foot orthosis. It can stretch it. But however, the use of hinge after during ambulation is unhelpful. We have what you call hinge after. Hinge AFO actually what it does is it allows for dorsiflexion, it restricts plantar flexion. Therefore, what hinge AFO does is you can dorsiflex, but you cannot plantar flex. Therefore, when you dorsiflex and you cannot plantar flex, then what happens is the gastrocnemius and soleus are rendered inactive. Therefore, you can use hinge AFO, but sparingly. Don't use it every day because the gastrocnemius and soleus can become inactive and it gives problem to the child. You can always stretch it because the child is overusing the gastrocnemius muscle. Then we have free active exercise. This is the mainstay of physiotherapy. They need free active exercise, not resisted exercise. Working within the parallel bar can help them. Physical activity, especially low impact activities such as swimming. Researchers have shown that hydrotherapy is the best form of exercise for them. Therefore, they do a lot of hydrotherapy. It helps their chest. Therefore, we have 3-wheel bicycle riding. Yes, for children that are not wheelchair bound, you can give them 3-wheel bicycle so that they can be riding. Walking exercise on their own. Walking between parallel bars, we have said it. We have high impact exercise such as trampoline exercise are contraindicated because these guys are having reduced bone density due to corticosteroid use. Therefore, when they are jumping up and down on trampoline, it is contraindicated. It can lead to fractures. Then we have high resistance training is also discouraged. Therefore, low resistance training using therapy standard is okay, but high resistance training in form of strength training is contraindicated. Here we can see two children within the age of 3 to 4 years doing aerobic activities, on bicycle ergometer, on tricycle. Then we have free active exercise also continues. You can strengthen the muscles of the back by encouraging the child to kick and throw balls. Therefore, when the child stands, you support the child, he kicks ball. You can ask the child to throw ball in sitting position. Or yes, throwing hard balls on the floor. It's as if one is playing basketball. Can help to strengthen the back. Also, you support the child. Low resistance training may be beneficial, but high impact resistance training is contraindicated. Then, the ways to improve and maintain lung function. The most important point is the patient must remain ambulant. Therefore, the therapist must do all they could to make the child remain ambulant. The second one, it is not that prolongation of walking reduces the rate of scoliosis. Prolongation of walking also reduces the rate of scoliosis. Wearing of CAPOS may prolong assisted walking. What are these CAPOS? Knee, ankle, foot orthosis. Therefore, anyone that they say, most especially with the one with active joint, they can help prolong assisted walking. Then we have chest physiotherapy technique, breathing exercise, postural drainage, assistive drainage. Home program should be taught. For home program, the child should be taught to blow balloon, colored cotton, wool, placed on the table. All those ones are part of it. Home ventilation for respiratory failure. Any child with respiratory failure, they must be given home ventilation. Therefore, they must buy a ventilatory machine. They should be taught how to be given respiratory ventilation. If not, the child is going to encounter serious difficulty. Then prognosis. There is no permanent cure for DMD. Up till now, there is no permanent cure. The life expectancy is 20 to 30 years. But they say children with Duchenne muscular dystrophy can live up to 40 years because of improvement in medical and rehabilitative care. Then in conclusion, we said Duchenne muscular dystrophy is an X-linked disorder characterized by progressive necrosis of proximal muscles in the body. The mainstay of treatment are steroid therapy and physiotherapy. Then there is no permanent cure for disease, and the affected children die within the 3rd and 4th decades of life. Thank you for listening. We are done with the second presentation. Now, comments, questions, and contributions.
I didn't understand that from the beginning.
Okay. Should I take some few minutes and rest?
Thank you, sir, for your wonderful presentation.
you, ma.
I have a question, sir.
I should take some. Okay.
Okay. Okay.
Okay. Ask the question, please.
You said high resistance training exercises is not advisable. What of sustained passive
sir.
stretching in cases of TA contracture? And
Yes, that is the most important thing they need. Sustained passive stretching. The child can also stretch on his own. When you ask him to sit down, and then since the calf is it's what you call
Tight.
dynamic what do you call it tightness, then he can be
Yes.
pushing such that the heel will be touching the wall, or to squat, or you do it. But high resistance training, we are used to saying, because at times what we see in the hypertrophy is as if the muscles are having bulk. We don't know that it's just a pool of fibrous tissue. The viable muscles are few inside.
Okay.
Therefore, we tend to injure them when we give a high resistance training.
Okay, thank you, sir.
Thank you, ma'am.
Okay, well done, sir, for your presentation.
Thank you, ma'am.
Okay. Sir, I wanted to know, can we use, I didn't hear you say anything about EMS. Is it contraindicated? Like for those proximal muscles?
Yes.
Like the quads, can we stimulate it?
Actually, there is no literature I have come across that gives EMS. Do you know the reason?
Why? No.
Yes, because actually you end up stimulating fibrous tissue. The muscles are very few, intertwined in the pool of something that looks like thread.
Okay.
Therefore, it's better you do free active exercise, something that is fun. Walking, you can help the child by holding the trunk, and you keep walking. You are walking behind the child. The trunk is the one that is giving him problem, because he cannot actually stand against gravity, except he pushes the shoulder and the hands backward. When you hold it, you keep moving. It's like create fun, but you can do free active exercise, most especially if the child is having weakness. You can put the child in gravity counterbalance position, and he can be doing exercises in gravity counterbalance position, such that you improve the strength of the quadriceps. But actually, I've not come across any literature that says we can give EMS.
It's okay. Thanks. Thank you, sir.
Thank you, ma'am.
Good afternoon, sir. Good afternoon, sir.
So we rest a bit before we come to the next presentation.
Sir, I have a question.
Okay, ma'am.
So, sir, I wanted to find out if those that have scoliosis are also contraindicated for them.
Actually, I didn't get you very well. It's like there's something is. Are you staying outside? It's like there is breeze where you are.
Oh, he's driving.
Hello?
Hello, sir?
Please come again, yes.
Oh, I think for those that also present with scoliosis, sir.
Yes, ma'am.
Are braces contraindicated, sir?
Those that come up with scoliosis, do you know where we used to have scoliosis? When the child become wheelchair bound. And by the time the child develops scoliosis, he must have been like 20 years or 22 or 25 years old. Already the spinal deformity has set in. You only need probably, you can give them braces to just support the back. Hello? Hello?
Thank you, sir. Thank you, sir.
Because it's scoliosis almost occur at the tail end of the disease, where the child has already become wheelchair bound. He has become fully dependent. Then it is just the process of lying plus the weak muscles in the spine that gives. It's better one prescribes thoracic for support, probably a corset.
Good afternoon, sir.
Good afternoon.
So I have put my question in the chat box.
Wow.
Or I can
Let me
read it
see
for
it.
you. Okay.
Yes, just read it for me, please.
Okay. I said for the child with DDM, you
Yes, sir.
mentioned that once they pass 2 to 3 years, still can be able to sit. It's hard for them to ambulate. So what of those that have hydrocephalus and underwent endoscopic third ventriculostomy?
Yes. They have ventriculoperitoneal shunts.
Yes.
Yes. Actually, we are saying children with what do you call it, most especially delayed milestone due to CP and the rest, because majority of the bulk of the work is done
Okay.
on what do you call it, on children with CP and some delayed milestones. Cool. For
Yes.
children with hydrocephalus is another case entirely, because it depends on the extent of the damage done to the brain. You can
Okay.
have communicating and non-communicating hydrocephalus, and one day we are going to discuss it, and then the different prognosis for hydrocephalus.
Okay.
Yes.
Thank you, sir.
Sir.
Thank you. Yes, sir.
Hello, sir.
Okay, I'm with you,
Hello?
sir. Hello, I'm with
Yes,
you.
sir. Please. Kindly go talk more on this discouraging strengthening exercises for the DMD.
Yes, what we are saying is that there are two factors. Strengthening, we did not say don't discourage, please, get me very well. I am not discouraging strengthening exercise. What I'm discouraging is high resistance exercise.
Okay.
Strengthening exercise, you as physiotherapist, you can put your hand on the quadriceps and ask the child, can you raise my hand?
Okay.
That is helpful. We are saying moderate strengthening exercise is good. But for you to
Okay.
now put sand back, and the child will be, yes, it's like going to injure the little viable muscles that are inside. But you can use strengthening exercises that will help the child. They benefit more with what do you call it, free active than with what? Strengthening exercise. Strengthening
Okay.
exercise, mild strengthening with the hands of the therapist or little weight is okay. But you don't do it as if the child is having normal muscles. And
Okay.
another factor, remember, yes, sir, I want, there is something I want to add.
I want to get the physiological explanation behind that. You talked about it, but then the network was jamming. So I just wanted you
Yes,
to.
yes, the reason behind it is that you remember for muscles to remain what do you call it, fully active, they have to what do you call, exercise their full tensile strength in both contraction and relaxation. Therefore, the major issue is the full of fibrous tissue are more in number than the viable muscle tissues. These muscles are intertwined between the full of fibrous tissues that look like sponge. Therefore, they don't allow them to contract fully. What happened is that what you are seeing in this guy is just full of fibrous tissues. The main muscles inside are very small. You don't overwork them. Remember, I said these children are fatigued easily. Remember, we said this. And the reason for the fatigue is that the bulk of muscle you see is fibrous tissue. The few muscles that are inside are actually what you call overworked. The whole essence of it is not to overwork these particular muscles. Hello? Hello? Hello?
I can hear you. I can hear you.
Yes, please go and read about the fibrous tissue and muscular dystrophy. They are intertwined. The viable muscles are intertwined in the full of fibrous tissue. They don't exert their full force. Therefore, they tend to become too fatigued. You work with them little by little, they become tired. Why then apply so much weight on them? That's one. You tend to injure the few muscles that are inside that cannot exert full tensile strength. It's better you do so much repetitions than putting so much weight on these children.
All right, sir.
Thank you.
Thank you. Thank you.
Thank you. Okay, any question again?
Yes, sir. Good morning, sir.
Okay, well, good morning.
Thank you very much for the presentation. I just wanted to ask, since you mentioned that corticosteroids and physiotherapy are the two main method of managing these guys, I wanted to ask because while managing children suffering with this condition, what other or what other practitioners are we supposed to be close to in managing them so that we can get effective results? Like,
yes, actually, if you have like you as a therapist, the prosthesis and orthosis department can help you with a CAFO, knee ankle foot orthosis, that will help the child prolong the walking ability of the child, which is very, very important. You can always put heads together. Then you come up with CAFO that would help the child prolong the working ability of the child. Another, what do you call it, individual, a professional. Actually, we said corticosteroids and physiotherapy, not that we're excluding so many people. Actually, cardiologists can be part of this one because of the dystrophin isoforms actually appear in the heart. Altogether, the pulmonologist can also be part of it. But actually, since it's a pediatric case, usually the pediatrician is the one that will see the reason for referring the child to a particular consultant, either the pulmonologist or the cardiologist or the physiotherapist. But you, the physiotherapist, you work most especially hand in hand with what do you call it, the prosthesis and orthosis people. But remember, any orthotic device that restricts what do you call it, movement may not be too useful for the child. Any orthotic device that helps the child move on his two legs are the most important device, most especially CAFO that allows for free movement.
all right, so thank you very much, sir.
Thank you, sir. Okay, so somebody is talking, but I'm not getting, the voice is not coming out. Hafiz, somebody is talking, but the voice is not coming out. Cool? Yes, I'm with you now. I can hear you.
Hello.
Hello, I can hear you. I can hear you. I can hear you.
Hello, sir. Can you hear?
Yes, I can hear you.
Just so far.
I can hear you. Hello.
All right, sir. All right, sir. I would like to ask for patients that make it to that make it to adulthood. Is this same management for as
wow, this network. Yes, if hello
that you give to those patients that yes, I can. I'm still on the line, sir.
Yes, you are asking whether for those that made it to adulthood, is it the same treatment you give to them?
Exactly. Yes, that's my question, sir.
Yes, actually, to me, we have managed children with muscular dystrophy, I think 3 or 4 of them. And what we really observe is that the routine is almost the same. But one thing that you should bear in mind is that as they are growing older, the complications tends to become more. Remember, with corticosteroid therapy, go and check, they tend to become heavier. You know, steroids used to interfere with what do you call it, insulin action. Therefore, the children tend to become heavier. Therefore, they tend to get more complications, most especially that has to do with pain, fracture, that has to do with contracture. You tend to do more when they grow older compared to children, sir.
Okay,
even the issue of dystrophin isotope appearing in the heart and the muscles in the respiratory muscles, actually they don't occur early, they occur late after 10 years or more. Therefore, they are the ones that actually respiratory and cardiac issues are the major causes of death in these guys. As the individual grow 30, 40 years, he tends to be more close to what do you call it, the chest physiotherapist or the respiratory or the cardiopulmonary physiotherapist and than the pediatrician. I don't know whether you get me. Hello. Hello. Hello.
I get you, sir. I get you, sir. I can hear you.
Yes, as the individual is past 20 years,
I can hear you, sir.
please hand him over to somebody who is in cardiopulmonary, because those ones are the major problem past 20 years. Cardiac and respiratory issues. Cardiac and respiratory problem are the major causes and cases you have with the few musculoskeletal issues.
All right, sir. Thank you very much, sir.
Thank you. Okay, let me have some little rest. Then when we come back, we can continue. Thank you very much for listening. Thank you for all your questions. I really appreciate it.
Thank you very much, sir.
Thank you, sir. Thank you. Thank you, sir.
Let's have a break. When should 1 hour break? So we'll come back by 2:10. 10 minutes past 2. All right. Thank you.
Karajina. I send many kills. PowerPoints.
They give Bobo in what do you call it? A lumber. Yeah, when did that guy leave? That guy was choked.
Left 2 weeks ago. But still coming out.
So he can now work on his own.
Just he's working, you know that okay, he has no working space is not perfect.
It's not perfect, okay.
You can still see the way he.
But what about the hand? Shall we can?
The hand too, you can fix for it. Also notice that it's not perfect.
That guy is so concerned. He came down to Nigeria to see whether it's fancy or something.
Like, eh?
My young boy, the guy we are seeing in face it in at 38 years, not even married. A young boy.
The one we saw 29 years old.
So the truth is, everybody should talk about it. This is not it's no longer an elderly like what the people think. Of course, I know that.
But even his own kids, he just came down to Nigeria to see the wife. People say this thing happen. Eh? I don't go come back to the
That's the guy, Abby.
family guy. Is that me a family?
Just imagine that.
The house.
Hey, I will call this man. Now I have a family, it's not like a family.
Yeah. And really see me, and he say the same. And the wife is not even peaceful. She have put up with that before I have it. And when
It came because of the lady, Abby.
Jenny seen the medicine, she went back. They should feel like she came here now. But I just think Yes, now you just put it there, what I've been listening.
Hello? Why are you doing that? Is it
Okay, good afternoon, everyone, and we are back from our lunch. Good afternoon, everyone.
Good afternoon. We are back.
Thank you, sir. We going to take some lunch. I'm going to continue. I think I when the rest on. I'm not the energy, but when you chat and feel. Okay, our next slide will be on cancer in pediatric population. Okay. Our next topic of discussion is cancer in the pediatric population, and by way of synopsis, we said cancer is not actually uncommon. It's common among children. And these cancers, or we call it tumors, or another name, malignancies, actually usually we physiotherapists usually come across some of these cancers. Usually they invite us to come and take part in the management of these children, especially when there is specific disability that requires the attention of a physiotherapist. Therefore, generally, the cancers can be grouped. I have the leukemias, that is the blood-related cancers. That's the two major groups. Blood-related cancers, we have what we call solid tumors. Solid tumors take 70%, blood-related cancer takes 30%. Then in the solid tumors, actually the one that is highest is the brain tumor, which is much more common than all other ones. Then in the hierarchy, we have the leukemia compost. Hello? Hello? Are we together? Hello?
Yes, we are together.
Hello? Hope the network is okay. Hello? Hope the network is okay.
Yes, it's okay.
Okay. Therefore, by way of introduction, we said cancer is a disease affecting the cells of the body, in which three things occur. The first one, we said the cancerous cells abnormally divide and producing a lump, or what you call a tumor. Therefore, when there is abnormal cell division, the cancerous cells continue to divide continuously and they produce a lump, or what they call a tumor. The second thing, characteristic of cancer, is that there are too many abnormal white blood cells, like in leukemia, like you are going to see, like acute lymphoblastic leukemia, where a lymphoblast, which is a precursor cells for lymphocyte, actually it's not a lymphocyte, but it's a precursor cell that tend to divide abnormally, then become leukemia. Then the third characteristic is that it can metastasize. When the cancerous tissues now break away, they will travel to other parts of the body via the bloodstream. Therefore, when we hear metastasis, meaning that cancer on one side has traveled through the bloodstream, or it has infected adjacent tissues. It has infiltrated them, and the tissues has the cells of the tissues have started dividing abnormally. These are the three characteristics of cancer. The cell, they abnormally divide, producing lump. Some of them, they produce white blood cell, abnormal white blood cells. They're like the lymphoblastic leukemia, we said. Others metastasize and break away through the blood, other invade other tissues. Then we said by way of division, we said cancers in children are divided into two majorly. We have solid tumors, meaning that tumors that occur in our tissues that we can touch in our solid tissues. Then we have leukemia, which is the remaining 30% that usually is a blood cancer. Then the common cancers we have in children that are under 5, that leukemia is part of them. We have embryonal cancers, we have neuroblastoma, Wilms tumor, we have retinoblastoma and hepatoblastoma. They found that these three usually occur, even among the children, they occur in children that are less than 5 years, meaning that are more common in the children less than 5 years. Then we have a little table here. Here we have leukemia taking 30%. Then all others here are solid tumors: germ cell tumor, retinoblastoma, bone tumor, soft tissue sarcoma, renal tumors like that's the neuroblastoma. We have sympathetic nervous system tumors. We have the lymphoma, Hodgkin lymphoma, not Hodgkin lymphoma. All these guys are what you call the solid tumors. Then the leukemia follows our blood. That's 70 and 30%. Then we are starting with the lymphoma and leukemia. They said it takes up approximately 1/3 of the childhood cancers. We said if you divide childhood cancers into two, solid and non-solid, then leukemia takes 30%, and is the malignant transformation of hematopoietic precursor cells in the bone marrow. Therefore, when we say precursor cells, cells that form our blood vessels, some will form lymphocytes, some will form granulocytes, some will form some are called myelocytes. Therefore, what they do is they would malignantly transform. Like example, I gave the lymphocyte, which is not actually what do you call it, a lymph forming. It's a lymph forming actually. What do you call it? Precursor cell, but it is not a lymph. It transforms. It becomes bigger and continue to divide, forming a lymphoma. Then we have there's an overproduction of immature malignant white blood cells as a result of transformation of the bone marrow. That is the leukemia. There are 4 different types, and then the whole of these types, the first one is the most common among children. That is the acute lymphoblastic leukemia. They call it ALL or all. Affect primitive lymphoblastic cells. Actually, lymphoblastic cells are supposed to form what you call lymphocyte, but actually they are not lymphocyte. They will now malignantly divide, becoming so big and that they affect the blood rheology. Then we have chronic lymphoblastic leukemia. We have acute myeloblastic leukemia and chronic myeloblastic leukemia. There are 4 different types. But the one that is of interest to us, that is common among pediatrics, is the acute lymphoblastic leukemia, or what they call all, and it accounts for 80% of the cases. The cause of acute lymphoblastic leukemia is actually unknown, and the highest incidence occur within 2 to 5 years. Remember, we said there are some lymphomas that are cancers that are very common among children less than 5 years, and all is part of them. Remember, we have talking about retinoblastoma and the rest. Then the risk for leukemia increases in patients with chromosomal abnormalities and immune deficiency state, meaning that for individual that is receiving a donor or a recipient of an organ, and yes, his body, because the treatment procedure requires that immune system has to be reduced so as to receive a donor organ, or somebody with HIV, or somebody with what do you call it, on treatment with chemotherapy for one cancer, and he is exposed too much to radiotherapy, then he may have leukemia. Therefore, chromosomal abnormalities like neurofibromatosis, all these guys are likely to be predisposed to what do you call it, leukemia. Then notable signs and symptoms of leukemia. Diagnosis of children often have a history of lethargy, bruising, general aches and pains, meaning that upon diagnosis, children that present with with leukemia may have lethargy, that is weakness. We have bruising of some parts, and they will have general aches and pains in their body. Probably after some tests, they will realize that they have leukemia. Many younger children may have stopped weight bearing, walking due to pain. That it is also associated with this body aches and pain may have some manifestation on their joints. Okay, then we have one of the mainstay of the treatment of leukemia is chemotherapy, meaning that using vincristine, vinblastine, all these drugs that are meant to treat cancer. They said one of the side effects of using them is that it can lead to gross and fine motor delays, meaning that somebody who is on chemotherapy for leukemia is likely going to be a physiotherapy patient. And in due course, we are going to see that it has also been recommended that all children that are having acute lymphoblastic leukemia should start physiotherapy immediately. Yes, because it can also lead to proximal muscle weakness. Therefore, they should start physiotherapy immediately as they are receiving their chemotherapy. Then they should also receive physiotherapy so that weakness will not set in. Then we have hyperextensibility of gastrocnemius and soleus musculature, decreased energy expenditure. They may suffer learning difficulties. They may suffer from avascular necrosis. Yes, part of the causes of avascular necrosis is exposure to either radiation of excessive, chemotherapy. Then they may have osteopenia or osteoporosis. But the most important thing is that these guys undergoing chemotherapy for acute lymphoblastic leukemia, it is advised that they should start physiotherapy immediately, such that whatever physical whatever sequelae they encounter due to that particular treatment can be managed by the physiotherapist. Then we now have brain tumors. We are done with leukemias. We have said acute lymphoblastic leukemia. We have acute chronic lymphoblastic leukemia. We have acute myeloblastic leukemia and chronic myeloblastic leukemia. There are 4 types, but the most important one to us is the acute lymphoblastic leukemia that is very common among children aged 2 to 5 years. Then after leukemia, we have the second most common type of childhood cancer, which is called the brain tumor. Then the brain tumors are actually depending on the area that is affected. The symptom depends on the area that is affected. Also, the management and the symptom, the clinical presentation will always differ depending on the area that is affected. Then generally, these are the divisions. We have supratentorial, we have infratentorial tumors. The supratentorial, we have the brain is divided into section by what you call the tentorial membrane. Some paratentorial tumors actually are the cerebral tumors, the tumors that occur in the main, brain tissue, that is in the cortical area. The infratentorial tumors are the tumors that occur below the tentorium. Then we now have tumors occurring in the cerebellum are called posterior fossa tumor. Yes, we have posterior fossa tumor, probably tumors in the brainstem and cerebellum. They are in posterior tumor, supratentorial tumors, and infratentorial tumors. Then we still have what we call the midline tumors, neuroectodermal tumors. All these ones are tumors. Okay, we have midline tumors. These ones are tumors that are deep-seated, meaning that they are not found superficial. Even when it comes to the issue of surgery, it gives the surgeons, the neurosurgeons, some difficulty. They are found within the central part of the brain stalk. We have the craniopharyngiomas, germ cell tumors, optic pathway, hypothalamic and pineal tumors. They are found right inside within the central nervous system. Then we have primitive neuroectodermal tumors. Their name is medulloblastoma. Another name for them is medulloblastoma. Majority of them are found in posterior fossa, just like the one we have the posterior fossa, the original from cerebellum, fourth ventricle, and the brainstem. Usually they are called medulloblastoma. Medulloblastoma. Then we have signs and symptoms of brain tumors. We say supratentorial tumors will usually present with increased intracranial pressure and seizures because they are affecting the cerebrum. Then we have brainstem tumors, often result in pulses along with hemiparesis, nerve pulses. The brainstem have so many nuclei of our nerve, cranial nerves, along with hemiparesis, probably because of the decussation at medullary pyramid in the brainstem, and then there is also ataxia, probably because of likely affectation of the cerebellum. Then we have cerebellar and fourth ventricular tumors, again increase in intracranial pressure and cerebellar signs. Then we have midline tumors. The presentation of midline tumors are likely that of cognitive impairment, memory loss, altered personality, and endocrine dysfunction because of hypothalamic affectation. Remember, when we go back to midline tumors, let's go back to midline tumors. You can see that it's a mixed type of tumor. They are deep-seated. We have craniopharyngioma, germ cell, optic pathway, meaning that vision pathway, hypothalamus. That is why we have then we have pineal tumors. Then we now come back to talk about midline tumors present with cognitive impairment, memory loss, altered personality, and endocrine dysfunction. Then we have neuroectodermal tumors, or what you call the medulloblastoma. They present with less intracranial pressure like the other three: hydrocephalus, headache, vomiting, ataxia, loss of balance, double vision, and facial weakness. But the most important thing is after CT scan, after MRI, they should be able to detect precisely where the tumor occur, and then you corroborate where the tumor occur and the symptoms. We now have medical treatments for brain tumors. Therefore, surgery and radiotherapy are the main treatment option for high-grade tumors, meaning that high-grade tumors that are tumors that are very malignant. They have the tendency to spread. Therefore, is the surgery, meaning the surgical resection, removal of that part, and then followed by radiotherapy, followed by using radiation to kill the other cells, is the best option. Then midline tumors, because having access to midline tumor is another wahala. Therefore, they are situated in deep-sighted. They said surgery is the best option and radiotherapy. But actually, it is being said that the role of chemotherapy from some of these tumors is being explored, meaning that hardly did they use chemotherapy for treatment of midline tumors, but they use surgery and radiotherapy. Then neuroectodermal tumors, with the one we call medulloblastoma, they benefit from surgical resection, radiotherapy, and chemotherapy. Then we now move to lymphomas. Lymphomas, meaning that tumors in the lymph tissue, and they are divided majorly into two. We have what we call the Hodgkin's disease and non-Hodgkin's disease. And the Hodgkin's disease is a chronic progressive neoplastic disorder of the lymph tissue. It is characterized by painless enlargement of the lymph nodes. Usually, it can metastasize to extra lymphatic sites, to the liver and spleen, and it is also painless. The etiology is unknown. The risk factor, they have queried Epstein-Barr virus. They have queried other infections also, like mononucleosis. Then they said men are more often than women, boys are more affected than girls, meaning that Hodgkin lymphoma is more common among men and boys when compared to girls. And the clinical signs and symptoms of this Hodgkin lymphoma include painless enlargement of the lymph nodes, at times in the neck, at times under the arm, that is under the armpit, at times it may be under the groin. And then the physiotherapists may palpate these nodes during cervical and shoulder and hip examination. There is what you call pruritus, that is itching over the entire body may occur. And then the patient may suffer unexplained fevers and night sweats. All this may point to what do you call it? May point to Hodgkin lymphoma. But the most important thing is the swelling along the lymph nodes are either in the neck or around the armpit region or around the groin region. It is the first thing to see, and usually it's painless and it's usually a lot. Then maybe there may be what do you call it? A follow-up by itching and unexplained night sweats. Then we have non-Hodgkin lymphoma. Then of every other lymphomas that are not Hodgkin lymphoma are classified as non-Hodgkin lymphoma. Like we have the traditional bucket lymphoma that usually has predilection to the face of the child. The face will swell up, and after some treatment, it will come down. That is part of the non-Hodgkin lymphoma. It's a etiology and risk factor for non-Hodgkin lymphoma. It's more common in adults in their middle age and older years. Male affected more than female, just like the way we said. Individuals with congenital acquired immune deficiencies, like we have HIV, those receiving organ transplant, they are immunocompromised. They are likely going to have non-Hodgkin lymphoma. Exposure to high level of radiation, nuclear reactor, extensive radiation or chemotherapy for different cancer may lead somebody, and we have said it before now. Then clinical signs and symptoms of non-Hodgkin lymphoma, just like for the Hodgkin lymphoma, we have painless enlargement of lymphomas can metastasize to distant site, other from the lymph node. This one have there may be palpable abdominal mass, there may be gastrointestinal tract involvement, complaints of back pain and back discomfort. There may be bleeding and generalized itching of unknown origin. Just like the other one, there was also generalized itching in non-Hodgkin lymphoma. It is just the diagnosis that will differentiate the two. Then we have neuroblastoma. Remember, we have said neuroblastoma is part of childhood cancers that occur below the age of 5. The tumor arises from cells in sympathetic ganglia and adrenal medulla, meaning that adrenal medulla that is of our own kidneys. It is the third most common pediatric neoplasm that occur in children aged less than 5 years, and the highest incidence at the age of 2 years. Meaning that when you talk about leukemia, you talk about brain tumors, and then after you remove the first two, this is the third one, that is neuroblastoma. The presentation is also in the abdominal area, is commonly associated with distant metastasis and carry poor prognosis. In this sense, meaning that whenever on examination you feel an abdominal mass, it can be an extension of non-Hodgkin lymphoma, it can be neuroblastoma. But they say neuroblastoma carries poor prognosis. Then we have Wilms tumor. Wilms tumor is what they call nephroblastoma. This also associated with the kidney. In the early childhood, the most common abdominal mass is Wilms tumor. It develops within the renal parenchyma and enlarges with the distortion and invasion of adjacent renal tissue. It occurs more often in children 2 to 5 years. Therefore, if you can remember, we have already also mentioned Wilms tumor in the beginning of this lecture, that they are the type of tumors that occur also in children less than 5 years. They say if it occurs bilaterally in 5% of the population, it may be associated with congenital abnormalities. Then, okay, another thing we should take note is that though physiotherapists don't manage, they were not the first line of management when it comes to the issue of cancer, but it's important to understand that the different types of cancers that exist in children, and we can be called upon to give our own contribution to the management of the child with cancer. Then we now move to bone tumors. The bone tumors are actually divided into two. We have the what do you call it? The benign bone tumors, and we have the malignant bone tumors. Example of benign bone tumor is what we call the osteochondroma. It's common in growing skeleton, and it hardly converts to malignant tumor. It remains as what do you call it? As what do you call it? Benign tumor. It will never metastasize. Then the two malignant tumors we have is osteosarcoma and Ewing sarcoma. Okay, osteosarcoma. Okay, the difference between actually majorly the osteo and Ewing sarcoma is that osteosarcoma occur in the long bones of the body. Therefore, your humerus, your tibia, your what do you call it, fibula, your what do you call it, your thigh, what do you call it, femur is the major area where what do you call it, osteosarcoma occurs. But in the other type, it occurs majorly on axial muscles, on axial bones, like those of the spine, those of the pelvis, those of the scapulae, and the rest. That is a major difference when it comes to predilection to a type of bone. Therefore, we said osteosarcoma typically arises in the metaphysis of long bones in distal femur, followed by proximal tibia and proximal humerus. The tendency to metastasize to the lung is in approximately 15 to 20% of children, and then it also leads to pathologic fracture in 5 to 10% of the children, and it carries poor prognosis. The most common presentation is pain that disturbs the child's sleep. There is also swelling and loss of function, particularly on a joint. Then we now come to Ewing sarcoma. We have said that the other one is more having predilection to long bones, but here the Ewing sarcoma affects mostly in flat bones, include those of the pelvis, the vertebrae, most typically the diaphysis. And they said the initial features are fever, weight loss, excessive soft tissue damage leading to nerve root pain and neuropathy. We have metastasis. The disease is found in 25% of children, mainly the lung, meaning that in 25% of the children, the disease can metastasize to the lung, meaning that out of every 100 children with Ewing sarcoma, 25 out of every 100 Ewing sarcoma are likely going to have metastasis to the lung. Then we have treatment of bone tumors. Here in the treatment of bone tumors, remember we said there is osteosarcoma, there is Ewing sarcoma, and then remember when we talk about the lymph, we talk about Burkitt lymphoma, we talk about all these things. Okay, chemotherapy, surgery, and possibly radiotherapy in the management of Ewing sarcoma. They said radiotherapy is rarely used to treat osteosarcomas. Therefore, it is rarely used. The most important thing is a limb salvage surgery. Therefore, where the tumor side of the tumor on the leg will be excised. Therefore, if the leg is the one that is affected, then the mid shaft of what you call it, tibia can be removed. If the whole leg coming to the tibia is affected, then there will be knee disarticulation. They will remove the whole knee joint. Therefore, that is why they call it limb salvage surgery, to salvage the limb. Say 85% of children with distal sarcoma have salvage surgery. They had salvage surgery, which involves excision of the part of the bone and replacement with endoprosthesis. Okay, what is an endoprosthesis? An endoprosthesis is what we call body replacement with technical function. We have an instrument that is used to replace the bone that has been excised during surgery. Therefore, it's a body replacement with technical function. You can endoprosthesis example, like when total hip replacement is done, the whole head of the femur and the whole acetabulum are removed and replaced with an artificial one. That artificial one is called endoprosthesis. Then we have retinoblastoma. That is the tumor that originates from embryonic lunar retina and is the most common intraocular malignancy in children. It can be unilateral, it can be bilateral. They said retinoblastoma is caused by mutation in a gene that expresses a protein central to the control of the cell cycle and may occur sporadically or inherited, meaning that just like the way we discussed Duchenne muscular dystrophy, you can have what do you call it, mutation. It will just occur that sporadically, or maybe as a result of genetic predisposition. Probably somebody what do you call it, transmit the gene that is susceptible to producing this tumor. Therefore, the retinoblastoma is caused by mutation in a gene that exposes the protein to the control of the cell cycle and may be sporadically or inherited. They said about 80% of the cases of the cases are diagnosed between the age of 3 to 4 years, and then all of the cases, about 60% are non-hereditary and unilateral, 15% are hereditary and unilateral, and 25% are hereditary and bilateral. Then investigation for central nervous system tumors. There are two major investigations that are available now. We have the computer tomography, and then we have magnetic resonance imaging. The computer tomography, that is CT, they said both CT and MRI are used to give diagnosis of brain tumor and to be able to differentiate it from other lesions such as infarct and abscesses, meaning that if there is a brain tumor, the computer tomography, that is CT, should be able to differentiate tumor cell from other abscesses or infarcts in the brain. Then MRI is used to localize the position of the tumor and its relationship with normal tissue. So they are just the same thing and is necessary for planning surgical. Yes, that is it. You need MRI to plan surgical intervention because MRI will tell the surgeon exactly where the tumor is and the surgeon will target that particular part of the organ that is having cancer. Then now treatment of cancer generally, we have said it before now, there is chemotherapy, there is radiotherapy, and there is surgery, and also there is chemotherapy. Chemotherapy here refers to the use of cytotoxic agent to destroy cancer by stopping them from growing or multiplying at one or more points in their life cycle. Meaning that when they use chemotherapy, what do you call it, agent, the whole role is either to kill the cancer cell or to stop the cancer cell from growing and reproducing. Then we have the main aim of chemotherapy are to cure the cancer, to prevent cancer from spreading, to kill metastasis, to relieve symptoms, and slow cancer growth. Okay, then chemotherapy also continue. Chemotherapy can be given via three routes: orally, or via intravenous central venous catheter (CVC). It can be given intravenously or through central venous catheter. Then we have intrathecal under the skin. It can be given intrathecally under the skin. Then we have chemotherapy effects on physiotherapy. Actually, there are two effects of chemotherapy on physiotherapy. We have talked about one here, and I have already mentioned the other one, where we have chemotherapy leading to core muscle weakness in some children. Therefore, we are the advice that chemotherapy should start immediately. The child is on chemotherapy. They said anemia, meaning that chemotherapy can lead to anemia due to chemotherapy may contribute to fatigue. We have low platelet level may occur due to chemotherapy, and then any low platelet level that is under 20 times 10 to the power of 9 and limits the use of manual chest therapy in order to avoid the risk of bleeding. Therefore, the risk of bleeding increases when there is low platelet count, and platelet actually is responsible for wound healing. Therefore, physiotherapists will always monitor the platelet count Therefore, if it is below 2 times 10 to the power of 9, then manual chest technique, manual chest physiotherapy should be removed from what do you call it, the treatment regimen. Okay, then we now have radiotherapy. Radiotherapy involves the use of high energy X-rays to destroy cancer cells. It is normally to use to treat one local area where the tumor was found. What they mean here is that it is normal, if you normally use to treat any area that is identified having cancer, then you can use the radiotherapy to kill the cells in the area. Radiotherapy is used in combination with chemotherapy, what do you call it? Chemotherapy and surgery. The three constitute what we call medical management. Then precautions after radiotherapy. Then we have looked about precautions after our chemotherapy. We talk about more especially anemia, more especially we talk about what do you call it? Reduction in what do you call it? The concentration of platelets. Then we now look at precaution after radiotherapy. They say it is recommended that children should avoid swimming 6 weeks following completion of radiotherapy due to effects on the skin, meaning that the skin has become sensitized. They shouldn't go for swimming. They should wait for a bit. Then physiotherapy management. Therefore, we have different types of cancers. We have different what do you call it? Presentation, our clinical presentation due to cancer. Therefore, but there is one physiotherapy. Therefore, how do we now know what to do? They said physiotherapy include prevention of secondary complication, respiratory infection, restoration of return to function following treatment. Okay, we have promotion of normal developmental progression in child. Then we have minimizing neurological sequelae from central nervous system treatment. What I mean, it is mean here is we minimize neurological sequelae following central nervous system treatment. What are the central nervous system treatment? It may likely be what do you call it? It may likely be resection, that is removing the part. May likely be what do you call it? Radiotherapy. It may likely be chemotherapy, but they are all what do you call it? Treatments. Then we have emotional and psychological support to the child and young person and parents, and yes, it's part of what physiotherapists will do when there is what do you call it? When there is a diagnosis and they say the child leg will be amputated, and the mother looks at the beautiful leg of the child and say this leg will be amputated. No, you just leave it like that. Therefore, they need emotional and psychological support. They cannot withstand seeing a child without a leg. The children probably may be mocking him. They may be calling him disabled. Therefore, they need little psychological support from you. They will now have, they said, following the insertion of Potacard, that is central venous catheter, many children present with neck and shoulder pain, stiffness, marked positional torticollis, and poor posture. What they are saying is that it's part of our own work as therapists. When a child is receiving chemotherapy via intravenous medication, and they put central venous catheter as if the central venous catheter is similar to the one they used to put for somebody on dialysis. If they put it and they want to administer the treatment, and the child come up with shoulder, neck pain, therefore, physiotherapists actually are in a good position to manage this one. Massage alone can treat that one. What do you call it? TENS can treat that one. Range of motion exercises can treat that one. Therefore, the posture of these children should be monitored throughout the treatment to prevent further lumbar and thoracic problem. Therefore, when a child, we can now see there is problem with central venous catheter for children. There is problem with what do you call it? Prolonged chemotherapy. They can also lead to some cancers also because of adjacent tissue. There is also problem with radiotherapy because it also leads to what do you call it? Reduction in it can also predispose to some cancers and can also what do you call it? Predispose to fracture of the bone. Therefore, physiotherapists might not be directly the first line of management of a child with cancer, but the sequelae of other treatment may brings about the what do you call it? The involvement of physiotherapists and actively. Then we have physiotherapy approach for all, that is acute lymphoblastic what do you call it? Leukemia, Remember, I've said this several times before I come to this place. We say proximal myopathy may occur due to high doses of corticosteroid during treatment regimen. Therefore, physiotherapy must begin early. Any form of weakness they see in the arm or leg, physiotherapy should now take over. Close monitoring of ankle range of motion, gait, and functional ability is required during chemotherapy. Then we have physiotherapy following CNS tumor. This is the one that is much more variable compared to all types of tumors because the different part of the brain have different functions. Therefore, for physiotherapy for management of CNS tumor is variable. It generally depends on the location of the tumor in the brain. If it is the one that is in posterior fossa, probably affecting the cerebellum, coming down to the midbrain, definitely is likely going to present with ataxia, with cerebellar signs. It's likely going to come with even sign of stroke because of the medullary pyramid. Anything can happen. It may be also be as a result of, it may depend on the part of the brain that is surgically excised. Yes, when surgery is done to remove a particular part, there is definitely going to be weakness or what do you call it? Yes, there is definitely going to be weakness due to the removal of that particular side because areas controlled by that side will never have central stimulation from the brain. Therefore, the physiotherapists have a lot of work to do. But it's also it depends on presenting symptoms. Therefore, the child may present with central nervous midline tumor. Therefore, if he presents with cognitive impairment, the physiotherapy would have to see how they improve cognitive function in this guy. Depends on that one. But therefore, central nervous system tumor may not have clear-cut management directly that it's all encompassing. It depends on the presentation. Then the aim of the therapy may be to improve cognitive function, to improve walking, and eventually start climbing, for example, for children. It may include assisting with activities, teaching with activities such as eating, toileting, and self-care. It may also involve the use of community physiotherapists for home assessment on how to involve the child. And then generally, one thing with what CNS tumors, as the child is improving, as the child recovers and is improving, actually the improvement in what do you call it, the condition and physiotherapy will help to together will help to foster further improvement in the child. Then we now have physiotherapy following lymph salvage surgery. Now, what we mean by lymph salvage surgery is they saw a tumor below the knee joint and they remove what do you call it across transtibial, or they saw it around coming to the knee and they remove the knee joint, or they saw it around the knee and they remove mid what do you call it thigh or hip disarticulation. This are what we call lymph salvage surgery. Not that they salvaged the limb. What they did was to remove it such that it will not metastasize and come to the body and kill the child. They said children with lower limb endoprothesis may mobilize initially with no partial weight bearing, progress to normal weight as pain and range of movement may improve. Therefore, usually if they have surgery and they have endoprothesis, usually there is what do you call it? Endoprothesis in form of replacement for neck of femur, probably replacement for what do you call it? A joint, anything endoprothesis, then they can be mobilized, partial weight bearing or weight bearing. It depends on your assessment, and then what do you call it? They may progress normal gait as they improve. Another big thing when it comes to limb surgery is amputation. Where there is amputation and there is no prosthesis, probably if somebody is to be fitted with an exoprosthesis. Exoprosthesis meaning that a prosthesis that you see outside, not the one that is put in the joint, like an artificial limb. Then physiotherapists have a lot of work to do in that particular instances. We have control of the thumb, thumb bandaging, and what do you call it? Thumb bandaging, training of what do you call it? The prevention of hip contracture. All these ones are related to what physiotherapists do. Therefore, but here are some general advices for children with endoprosthesis, meaning that prostheses that are within the joint or within the body that you cannot see them outside, like cement or cementless, like no contact spot. You cannot ask the child with an endoprosthesis to go and have contact sports, so that like football or anything, the endo prosthesis may get loose, or high impact activities like trampoline exercises, like jumping from one height to the other, no running and twisting. Therefore, then we have lifting of heavy objects, most especially upper limb prosthesis. Therefore, these ones are very important. Then we now have physiotherapy following amputation. There is amputation. The leg entirely is excised. Somebody, it may be that the child may not afford to put anything in what do you call it, artificial limb. They may want to go with the amputation, or they want to put artificial limb. If they want to put artificial limb, there is a lot of things that the child will learn from the physiotherapist. And there is, first thing we do is psychological and emotional support to the children and their families. We have said it, counseling, because of the new appearance of the child, experience by the peers, probably they may be mocking him, and probably the issue about independence, is he going to be independent? Then we have phantom limb sensation, itching, burning sensation. They may be treated by drugs, they may be treated by transcutaneous electric nerve stimulation, they may be treated by physiotherapists using the distraction or relaxation therapy. All these ones are important, but actually stump bandaging, training for the use of prostheses are also very important. Then we are coming gradually to the end. Then contraindication for aerobic exercise. If somebody is undergoing, this is another issue with chemotherapy again. If somebody is undergoing chemotherapy, then remember we talked about platelet count before. If we can go back, let me take you back to the platelet count here. You can see here we have platelet count. We said anything under 20 × 10⁻⁹, we should not use chest physiotherapy because of what? Because of bleeding issues. Therefore, the platelet counts are less. Here, now they said low platelet count is contraindicated for aerobic exercise. Here, this one is, the other one is 20,000. Less than 20,000 you cannot do. But this is less than 50,000 platelet count. Here, they said, don't give aerobic exercise. This is not my say. This is Winningham contraindication for aerobic exercise. They said, if anything platelet count less than 50%, don't give aerobic exercise. Therefore, they said hemoglobin less than 10 milligram per deciliter. You know, the usual normal value for hemoglobin is 12 to 18 milligram per deciliter. But actually, you can give mild aerobic exercise. I think is a moderate aerobic exercise. You can give mild aerobic exercise. White blood cell count less than 3,000 per millimeter cube. Then we have absolute ground cell less than 2,500. But this is being gotten from Winningham indication for what aerobic exercise. You can give mild aerobic exercise should be symptomatic. Whenever the individual becomes fatigued or becoming dizzy, then you can stop it. Then we now have, in conclusion, we said cancers in pediatrics are not uncommon. They range from leukemia, CNS tumors, bone tumors, lymphomas. They talk about you can have pediatric, what do you call it? We have retinoblastomas. We have the PANETs, that is the what do you call it? Medulloblastomas and the rest. We said medical treatment include chemotherapy, radiotherapy, and surgery. Then we now have the therapists treat sequelae of both cancers and cancer treatment. The sequelae of the cancer is what the cancer brings about: movement difficulty, cognitive impairment, what do you call it? Impairment of central nervous, what do you call it? Peripheral nervous system function. Part of what the therapists can do, and then the also sequelae of cancer treatment. We can see that chemotherapy can cause a lot of what do you call it? Has a lot of sequelae on the children, from proximal muscle weakness, coming down to affecting the platelets counts, coming down to so many things that the therapy will take care of. Then thank you for listening. We are done with this. Then we have questions, comments. Hello. Hello. Hello.
We can hear you, sir.
We can hear you.
Yes, generally, when we look at pediatric cancers, cancer is not the repertoire of the therapist, but we have a lot to do as a physiotherapist. I have gone to the ward several times. because of inability. We have some disabilities, inability to function. They'll invite physiotherapists to see with some cancers. At times, the name of the cancer you may hear the name for the first time. But what we are saying here, what we discuss may not be all extensive because there are so many cancers, but we are able to at least introduce the different types of cancers that we have in the children. But the most important thing is that after the treatment of cancer, due to where the cancer affects either in the brain or in the brain stem or in the bones, and then following also chemotherapy, following radiotherapy, there may be sequelae that the therapists should be able to handle. And we said if we really have this knowledge, we can build upon, and it's going to help us as we interact with other colleagues. Thank you very much. I may give the floor for you to ask questions.
Thank you very much, sir.
Okay, thank you, sir.
Hello,
All
sir.
right, so hello, can I go first?
Yes, you can talk.
Thank you, Dr. Badaru, I think, for that mesmerizing topic about pediatric oncology. It concorded with me because I'm currently following on patients with adenocarcinomas gastric. So I was just interested or rather curious about the issue of manual chest physiotherapy for patients with low platelet counts. Does that exclude other interventions to clear the tracheobronchial airway? Please, could you elucidate further?
No, sir. They said yes. What they said is, we are used to doing percussions. We are used to doing assisted coughing. At times, you shake the chest wall. It's like what they are saying is they don't want any internal bleeding around the what do you call it? The lungs. Therefore, it's like active shaking, vibration, percussion is what is being
discouraged,
contraindicated. Yes, because of poor, what do you call it, a very low level of platelet level due to what do you call exposure of, what do you call it, for prolonged exposure to chemotherapy. I remember they said one thing is you measure the, what do you call it, probably after the what do you call it, laboratory test should be able to indicate whether there is improvement in the platelet or there is reduction in the platelet. And another thing, thank you very much. Another thing is that remember, we physiotherapy should also be interested in all these laboratory tests. The parameters are also going to be of importance to us. Somebody you are putting to do some aerobic exercise, having what do you call it, hemoglobin concentration less than 10 milligram per deciliter, definitely he's having low hemoglobin level. Probably he needs more blood, something like that. It is high time for us to start having interest in some of the laboratory parameters. They will be very, very good, and we'll have something to be able to discuss with the oncologist.
Thank you very much. Point taken.
Thank you, sir.
You have.
Hello?
Can
Hello?
you hear me, sir?
It's like the voice is faint. Hello?
Yes, sir. Can you hear me? I do have a question.
Yes, I can hear you now.
All right, sir. With cancer, we know one of the common symptoms that actually presents with these patients is actually pain. So I want to know, is there a particular modality that is perfect or that is preferred for managing pain in patients with cancer?
Actually, in physiotherapy, I don't think there is anyone greater, most especially for those with metastasis. Actually, they benefit more, what do you call it, from TENS than any other than, because like hitting modalities, we are talking here, what we are discussing here is people that are on treatment. people that have started receiving treatment, what do you call it? They are on either chemotherapy or radiotherapy or this specifically. But you know, most electrotherapy modalities, if a patient is not on treatment, most especially the heating modalities, all these ones, they are contraindicated because they can lead to metastasis. But one, what do you call it? One modality that actually have not gotten that contraindication attached to it, I think, is the TENS therapy, sir.
Thank you very much, sir.
And it's possible again, sir, when the tumor has been excised and the treatment has progressed, they have assessed that they have really dealt with it, and the individual is coming with some squally or back pain. I think all other modalities can be used. Only that one should be careful, such that somebody that is having active cancer based on the diagnosis, then other modalities may worsen, most especially heating modalities, because the cancer may spread through hematogenous routes. Thank you, sir.
Thank you, sir.
Thank you, sir.
Hello, thank you very much for the question and also for the presentation. Regarding the last question being asked now, what about cryotherapy? Is that also like contraindicated, or is not, like, how is it
No,
like for
cryo is not contraindicated. Cryo is not contraindicated. We said electrotherapy modalities, ma. Cryo is not an electrotherapy modality. It's another modality on its own. Yes, it's another modality on its own.
Thank you for the presentation, sir. I was going to ask on assessment of these children. Since cancer is a red flag, what should we like look out for? Because if a child is brought into the clinic and we are trying to like rule out the red flags, what should we look out for, except for the lethargy and the pain? What questions should we ask to like probe answers that will tell us this is a red flag?
Yes.
Thank you, sir.
Like, for example, one very good thing that used to come, you see an abnormal, what do you call it, dysmorphism, facial dysmorphism. The head begin to grow somehow. You know, definitely this is unlikely. You may likely say, you refer them, let them go and see a specialist. Or you palpate an a mass in the abdomen, Ewins, what do you call it, Wilms, tumor, all these ones, probably a mass around the kidney. When you palpate a mass or anything that is giving pain, but when you really palpate, this is a mass. The mass may be, what do you call it, cancer. Another thing is that we physiotherapists, when we manage, at times we manage children with pain in the leg, pain in the hand. If the pain did not go, it's better we ask them to go and seek, what do you call it, for their medical attention. It is likely that the children may be suffering from probably acute lymphoblastic leukemia. The child does not want to put leg on ground. The child is having, they never want to bear weight on the leg, some pain in the extremities. Probably is possible. But generally, there is something we also have to understand, we as therapists, by the time we are being called, the child, we don't even know when the diagnosis of cancer is made. We are being called upon to just, what do you call it, participate in the management of the child. Usually, hardly will you see a child having cancer coming to the therapy department. Usually, only, but it's okay for us to be able to discern that this is likely going to be cancer, and we'll send patient to them. Like, for example, I will say, like around the lymph node in the neck here, a swelling that is not tender. You may likely suspect something. If they give drugs and the drugs did not go, and probably ask them to go and check, probably under the armpits, more especially the Hodgkin's lymphoma. And then non-Hodgkin's, like Burkitt's lymphoma, is very okay. It's very obvious. It affects the whole face. You can easily see the child's face is, what do you call it, swollen. You know, it depends on the type of cancer, sir. It depends on the type of what? Cancer. Yes.
Thank you.
Okay, thank you for listening. we are going to look at the next presentation. Hafiz. Okay, here we are again. Thank you for listening. We are going to look at, before we take a little break again, we are going to look at acute, what do you call it, juvenile rheumatoid arthritis. It's part of the conditions we are likely going to encounter in pediatric practice. Juvenile rheumatoid arthritis. By way of introduction, we say juvenile rheumatoid arthritis is also called juvenile idiopathic arthritis. By hearing the name idiopathic, we mean it is of no known origin, meaning that one cannot say this is the real true cause of what do you call it, juvenile arthritis. It is thought that is an autoimmune what do you call it, disease affecting the connective tissue of the child. And then we know autoimmune disease where the body antibodies attack its own cells. Then it is characterized by peripheral joint synovitis, inflammation of the synovium, with soft tissue inflammation and effusion, meaning there is joint effusion. Then it starts before the age of 16. Please, this starting before the age of 16 is a big criteria in assessment of juvenile rheumatoid arthritis. Any arthritis that did not occur below the age of 16, then it's not a juvenile rheumatoid arthritis, one of the criteria. And then another criteria is that the joint symptoms must last more than 6 weeks, meaning that if the joint symptom, somebody coming to tell you there is swelling in the leg of my child, and after, let's say, 2-3 days is gone, that is not rheumatoid arthritis. And then if it does not occur in more than one joint, it's not rheumatoid arthritis, juvenile rheumatoid arthritis. But the most important is that the symptom, despite treatment and everything, the symptom lasts more than 6 weeks, then it can be part of the criteria. Then etiology of juvenile rheumatoid arthritis, as we said, from the name, juvenile idiopathic arthritis, the other name, the cause is unknown, but it's an autoimmune disorder where the body immune system attacks itself. Then they said, though it is what do you call it, the cause is unknown, but they believe that environmental triggers, there are some environmental factors that are actually being pinpointed at. Example, we have viral diseases such as rubella, that is German measles, and parvoviruses. They have implicated as triggers of this disease expression. But you know, whatever, this is a hypothesis, this is our literatures based on some researches, but generally it is unknown. Therefore, criteria for what do you call it, diagnosis of juvenile rheumatoid arthritis. Remember in the first slide, we have said the symptom must last at least 6 weeks. Yes, if somebody has just a child starts to develop symptoms and then within 1 week it's not likely going to be juvenile rheumatoid arthritis. I have seen so many literatures, the emphasis is on 16, it must be less than 16 years, and the symptom must be sustained up to let's say 6 weeks, then it is likely going to be that. Then we have the arthritis or swelling or effusion or the process of 2 or more of the following, meaning that after having the criteria of 16 years, then another criteria is that of arthritis. And then remember we said arthritis must be at least 6 weeks. It does not go. And then this arthritis present with swelling or effusion, that is collection in the joint, and the presence of 2 of the 3. 1, limitation of range of motion, tenderness or pain with motion, meaning that whenever the therapist or the parents move the leg passively, the child feels serious pain. And then we have increase in heat, meaning that increase in joint heat in greater than 1 joint, meaning that the arthritis actually affects more than 1 joint. Then it's likely going to be juvenile rheumatoid arthritis. Then we have classification of juvenile rheumatoid arthritis. There are 3 principal types of juvenile rheumatoid arthritis. We have what you call a polyarticular or polyarthritis. That is, it affects 5 or more joints. Then we now have polyarticular or oligoarthritis, affects 4 joints or less. Remember, polyarthritis affects 5 joints or more. Oligoarthritis or polyarticular affects 4 joints or more, and systemic disease is an arthritis that also comes with intermittent fever and skin rash. Therefore, then, like for example, we have polyarthritis. The one that actually has better prognosis among the 3 is the polyarticular, the one with less than 4 joints inflamed. Then the one that is more severe compared to that one is the polyarticular, which up to 20 small and big joints of the body can be affected in polyarticular. But when it comes to fatality, death rates occurring, then it is a systemic type that can lead to death. But nearly all of them, certain percentage of these children are likely going to adulthood with a certain level of arthritis in their bodies. Okay, then let's start with polyarticular. Polyarticular, we said the name is what do you call it? When you say polyarticular, we mean those one in which less than 4 or less than that joints were affected. One of the features of it is like limb length discrepancy occurs due to an asymmetry of knee synovitis. Therefore, if the knee joint is affected, one of them is inflamed, the other one is not inflamed, or the other one has the cartilage damage, the one that has no damage, there will be slight difference in limb length, and then the bone growth may contribute to flexion contraction and gait abnormalities. Actually, there is something with juvenile rheumatoid arthritis in general. They can lead to bone retardation, growth retardation. Therefore, the bone may not grow, probably because of some treatments, but actually they are predisposed to bone joint retardation. Another feature of polyarticular, it is among the 3, it is the only one that prevents with eye inflammation. The ones with 4 joints or less is the one that presents with eye inflammation, and it may lead to scarring or blindness in 15 to 20% of the children. Therefore, for those with polyarticular, they may have ophthalmology exam, meaning that the ophthalmologist or the optometrist should be able to examine them at least 4 times in a year. Then they said active arthritis may extend in 40% to 50% of these children. And I have said it before, for those with polyarticular, or what you call the oligo, or what do you call it, arthritis, these guys are likely 40 or 50% of them are likely going to adulthood with arthritis. Therefore, radiographic joint damage is seen within the first 5 years of onset, meaning that if it really occurs, if it is juvenile rheumatoid arthritis, within the first 5 years of onset of this pain, radiographic damage in the knee joint is likely going to be seen. Then RH factor is negative in 98%. What is this RH factor? It's rheumatoid factor. Therefore, when they test rheumatoid factor, they are likely going to see it's negative, meaning that they don't have rheumatoid factor like what do you call it? The elderly people that usually have rheumatoid positive rheumatoid factor. And another thing is that children with positive rheumatoid factor, though they are few among them, but they usually have poor prognosis with. Then they said no body erosion on X-ray. They are not likely going to see bony erosion, but there may be damage within the cartilage. Then we now have polyarticular. Polyarticular is the one we said that 5 or more joints are affected. Here we have symmetrical presentation, meaning that both legs can be affected, where you have large and small joints, and up to 20 joints may be involved. This is more severe compared to oligoarticular, the one we call polyarticular. Here, the difference between this one and the other one, observe, the other one affects the knee joint, it affects other joints, but actually peripheral to the body. But observe this one, it affects the cervical spine, costovertebral joint, temporomandibular joint, meaning that it's more common. It can affect after the joint in the periarticular or joint in the body. It can also affect the joint in the spine, what do you call it, joints in the face. Meaning that, because I remember we said 20 joints can be affected at the same time. This is more widespread. And they said it's more common among girls. They said it's more common among girls. They said prognosis for patients with particular is not as favorable as what? Polyarticular. It's not, what do you call it? It's not as favorable as compared to polyarticular, because usually most especially those with RF positive. Those with RF positive, rheumatoid factor positive, are likely going to have an unfavorable prognosis. Then they said active arthritis may extend to adulthood in 50 to 70%. Okay, now let's go back and observe this. You can see active arthritis extend between 40 and 50% of the patient. 40 to 50%. The other one is saying up to 70%, meaning that majority of these guys, up to 50% of them, are going to leave juvenile arthritis as a young person. They will not suffer it as adults. But here, look at the one with, what do you call it, with polyarticular. Almost 70% of them are now going to adulthood with juvenile rheumatoid arthritis. And they are likely going to suffer long-term disability in 30 to 40%. That is why in the presentation I said, when you have polyarticular, have fewer complications compared to polyarticular, has fewer complications, but the ones that lead to death, is systemic one. That is it. Then we have long-term disability is more associated with polyarticular because more and more joints are affected, likely. And then this one also can lead to growth retardation. But remember, we said all of them can lead to growth retardation. One is more, leads to growth retardation more than the other one. Then we now have systemic juvenile rheumatoid arthritis. Here, this is the least common. There is something we have to understand, that systemic is the more fatal, but is the least common, meaning that it does not occur frequently. But when it occurs, is what? More fatal. Then they said the least common type of GRA occurring in only 10% of the patient. It has no gender dominance, where male or female. It's like both male and female children can be affected equally. Active arthritis occur 50 to 70% of the patient, just like in the polyarticular. Long-term disability can occur in 30 and 40%, just like in the polyarticular. Radiographic damage seen in the 5th years of damage, in the 5th years of onset. But here, look at it, greater mortality with what? Systemic GRA than with polyarticular. One thing again, it can lead to what? Greater mortality. And then remember, we said systemic GRA in GRA, juvenile rheumatoid arthritis, presents with what? Fever and rash. We have what you call the rheumatic rash, for the myopathy, hepatosplenomegaly, and anemia. Therefore, it can present with high fever, probably that is the cause of the death. It can prevent with inflammation of the spleen, hypersplenomegaly, It can present with anemia and lymphadenopathy. Therefore, that is probably the cause of the death. Then disease-specific measures. Yes, like we discussed before, you cannot come to Duchenne muscular dystrophy where you use Vignos, what do you call it, the rating of Duchenne muscular dystrophy and say you want to use it for what? Juvenile rheumatoid arthritis cannot work. Therefore, it has to be disease-specific. Therefore, this one also has disease-specific measures that I would want you to go and look at them. The first one is Juvenile Arthritis Functional Assessment Scale. We call it JAFAS. And then we have Juvenile Arthritic Self-Report Index. Each one of them, you can use it to report juvenile arthritis. What do you call it? You can grade the juvenile arthritis using it. You can use it to grade whether there is improvement in the treatment you are giving based on the scoring. Okay, now, aim of management. We are coming to management of children with rheumatoid arthritis. The aim of the treatment goals are to control inflammation, because inflammation and effusion are the hallmark of juvenile rheumatoid arthritis. Pain is there, inflammation is there, effusion is there. Then we have restriction of joint movement. Probably we have articular damage before joint bone erosion. Then we have control of inflammation, relief of pain, prevention of joint damage, maximize joint and body function and participation. All these ones are aim of our treatment. Here is, they said the trend in juvenile rheumatoid arthritis management has shifted in the last 10 to 15 years and now tends to be more aggressive in the earlier disease course with the aim of preventing and slowing the progression of joint damage. What they are saying here is that when there is early diagnosis, then aggressive treatment should be given in order to slow the progression and joint damage. And the aim of doing this thing is to prevent children with juvenile rheumatoid arthritis going to adults having arthritis. Therefore, and based on the fact that you can see in some 40 to 50%, in some 50 to 70%, how do we now get, if at least 10 to 20% are the ones now going into adulthood, then it will do more better to those affected. Then we have medical management. The medical management include corticosteroids use. You can see we have said corticosteroid severally. This corticosteroid is used to reduce inflammation. Therefore, this corticosteroid is likely going to make the bones brittle and predisposed to joint damage also. Corticosteroids like NSAID, corticosteroid, disease-modifying anti-rheumatic drugs such as methotrexate and sulfasalazine, and biological response modifiers. Growth hormones may be used to address growth dysfunction. Therefore, where they have growth dysfunction, they can give growth hormone. Joint replacement or soft tissue release may be used in later stage of the disease. Somebody will say, joint replacement, yes, where there is, remember we said polyarticular and systemic disease can lead to long-term disability. Where the joint is damaged, you can have joint replacement. You can have knee replacement, you can have all these ones. Where you have contracture due to poor management, they can have soft tissue release by surgically, such that they can release the contracture. Then the nutrition and weight management. What brings about nutrition and weight management is because of corticosteroid prescription. Any child that is on corticosteroid for a long period of time will be as if he is a diabetic patient, because corticosteroid used to affect metabolism of glucose. Therefore, there will be a lot of glucose in the bloodstream. Then that will lead to increase in body weight. The child is likely going to have increase in body weight. Therefore, nutrition would help to maintain body weight and to minimize excessive joint forces, meaning that to minimize weight being transferred to the joint. Then we have rehabilitation management. Here we have strategies there are two strategies in rehabilitation. Strategies for joints that are not flare-up, not in active disease, meaning that the child is having it, but not in the period of exacerbation. He is coming regularly. This is what we need. And then where there is exacerbation, the disease has because there is what we call exacerbation and remission. Therefore, a time will come when the disease will become a new episode of pain. Therefore, there is a strategy for that one, and there is strategy for the regular treatment. If we start with the strategy for regular treatment, we may need strengthening exercises, range of motion exercise, and important adjustments to maximize function. Therefore, range of motion exercise, strengthening exercise will increase the, what do you call it, the strength of the muscles and of the ligaments that are controlling the joint, so as to relieve some pressure on the joint. Okay, joint splinting, particularly for knee and wrist, may help maintain range of motion and relieve pain. Therefore, you can split the joint. You can use what do you call it? Taping, splinting. You can do it. Okay. Then moist heat, wax therapy, usually is affected. What do you call it? This is one of the most important treatments for juvenile rheumatoid arthritis, and one of the important treatment for adults with rheumatoid arthritis is wax therapy, whether it's immersion technique, whether it's deep immersion, whether it's whatever technique you have to do, is very, very important, and it relieves a lot of pain. Gentle range of motion exercise. Cryotherapy can also relieve what do you call it, characteristics of morning stiffness. Then most students can take part fully in physical activities, but with non-contact sports until symptoms are under control. Therefore, when a child is having juvenile rheumatoid arthritis with all the body joints and pain, and he goes to play football or any contact sport, it's likely going to exacerbate the symptom. During the disease flare, the limiting certain activities can be necessary until the joints, depending on the joints involved. Okay, we are going to discuss in the next slide where the disease is flare up, where the inflammation comes back, despite the fact that the child is receiving treatment. Remember, the treatment is not just for 1 week or 2 weeks. It's a treatment that will last for several years, 2-3 years. The child will be coming gradually until it overcomes it. Where there is flare up, then another approach will be given. Okay, here, management continue. During active phase, rest and joint protection. Therefore, where there is flare up, there is need for rest and joint protection. We have to protect the joint. The first thing is rest is key component of the management of this arthritis, and include both general and joint specific rest. What is the general rest? Somebody having what do you call it, polyarticular, the spine, everything is having the pain. Therefore, the individual should rest. 8 to 10 hours of sleep will be indicated. Let the child sleep so as to overcome the pains. Then there may be 30 to 60 minutes of rest during the day. Then we now have rest periods to avoid undue fatigue and joint flex. You can also, what do you call it, where the child is going to school, you can also devise a rest period to avoid undue fatigue. Probably, even if they are doing some little play in the playground, you can be devising ways for him to have some, what do you call it, rest period. Then we now have provide period of unloading. Use of what? Brace for support. Use of brace for support. Like, for example, in the knee joint, you can provide brace for the child. There is flare up. Before, you don't use brace. But now, the child has come with a flare up. The knee joint has flare up again, and he has to keep walking. You cannot restrict the whole movement. Then you use a brace to remove, to support the joint. Then they said we have to promote function and activity in spite of swelling and pain. Therefore, in spite of swelling and pain, cryotherapy can be done for the child to reduce the swelling. They can apply bracing so as to reduce weight on the joint. You can also do the splinting that we said to reduce weight on the joint, or to reduce what do you call it, excessive use of the joint. Then activity can continue. Joint specific rest may include activity modification. We can modify the activity of the child. If we see that the way the child does something is the one bringing pain, then you can modify the activity of the child. You can observe what the child is doing and modify it to activities that will not give pain. If at all knee joint issue, walking gives him more pain, then we can say, okay, non-weight bearing exercise on pediatric bicycle ergometer, and these guys to be doing in sitting, it can also reduce pain. Then use of assistive devices and adaptive equipment, we have said it. Protective supportive sleeping, splinting can be done. Then we talk about electrotherapy. We have low-level laser therapy. Trials, meta-analysis and clinical trials, that is from researches, have shown that low-level laser therapy can reduce pain and morning stiffness and increase range of motion than placebo in intervention in individuals with rheumatoid arthritis, juvenile rheumatoid arthritis. But remember, don't apply ultrasound. Don't apply ultrasound to children with rheumatoid arthritis because of growth plate. They have big issue with growth retardation, most of them. Therefore, when you apply ultrasound to their joints, the epiphyseal plate is going to dry up and the child is not likely going to grow. Therefore, we don't apply ultrasound to the epiphysis of the child. Therefore, low-level laser therapy is okay. Then we now have cold therapy. We have found researches that shows that improves function. Heat therapy, we have found is that we have said it gives anesthesia and analgesia. We have, in our conclusion, we say juvenile rheumatoid arthritis is found in children less than 16 years, and it can be polyarticular, polyarticular, and it can be systemic. The systemic has higher fatality rate, but less common than the first two types. And we said, thank you very much for listening. Are we together?
Yes, sir.
We are done with the second lecture. We are going to take a little recess. Okay. Questions, comments? Okay, we are going to have a little rest. Let me prepare the last part. The last part.
Okay, thank you all. Let's have a 30-minute break. Resume by 4:30. Then we take the last part.
le doute.
Kai so muke yi. Wallahi yanzu akwai opportunity da yawa. Wataƙila za ka gani a kan photography wannan za ka gani lokacin za ka kai skyline ne sai na kana nan neman staff. Sai har akwai opportunity. Sai ka ɗaura ne. Sai ka saka shi wani registration na masters. Obvious. No ke registration na masters. Mine is Kasan amma kan masu yanzu ka ga suka tsina ne ina ne duk suna fara. Ana nuna mani sai ko kaske duk an fara samu programs. Sababbin a ina kenan. Can school ne? Yes, makaranta ce. Ko mai lecturer.
Assalamu alaikum malam.
Aina alaikum assalam. Na wuni na gajiya.
Lafiya. Ya kokarin Musa. Sa? I've been online kawai. Ina ta bacci ne ba da lafiya sosai amma na dan samu sauki sosai. But we still get the recording link, right? Saying so that we listen to it very well.
To, basha Allah, to Allah ƙara lafiya.
Amin.
Kice har yanzu kina pediatrics?
I'm still in my pediatric. Ina son tara kudi ne zan fara PhD.
Wallahi ki tara.
Ko ba fara PhD a pediatric ba.
Wallahi an fara masters ne suka hana mai.
Okay. We are coming, sir.
Amma PhD sun hana mai. Ai mu masters sun hana mai muna PhD.
Dama bayan namu ne aka hana.
Sun ce masters ya mana yawa, sun hana min community, sun hana they stop 4 of them suka ce sun yi yawa.
Yeah. Amma malam, instead of the PhD ko in je DPT ne, which one are you thinking?
To kin gane kowanne yana da nashi amfanin.
Okay.
Amma we talk later.
Inshallah. Na gode.
Tunda yanzu free ake magana.
It's true. Thank you,
thank
sir.
You,
I guess iyali.
Yawa za su ji insha Allah. Okay, good afternoon, everyone. We are back. We said let's observe prayers and come back. Are we together? We are taking the last module today. We are looking at osteonecrosis or avascular necrosis. Hello? Hafiz, are we on?
Yes, we are with you, sir. Go
Okay,
ahead.
thank you. So thank you very much. We are taking osteonecrosis or what we call avascular necrosis. And this actually is another vast field. But since we have taken the bold step of saying we want to take osteonecrosis, what I did was to restrict myself to where we are going. But actually, it's another vast area. Osteonecrosis or what you call avascular necrosis can occur in any part of the body. It can occur on the bones in the scapula, bones in the leg, not just what do you call it, at the hip joint. It can occur anywhere where there is defective arterial supply, but actually it's much more common somewhere. Therefore, by way of introduction, we said vascular necrosis is also called ischemic necrosis or osteonecrosis. It's the necrosis of bone due to ischemia. When we say what do you call it, necrosis of bone due to ischemia, where there is effective blood supply. Then the most disabling in the hip area affecting femoral head and neck, meaning that why that of femur is much more what do you call it, common in the literature is because it's the most disabling. The femoral neck has limited terminal. They are telling us probably part of the reason why we used to have a vascular necrosis of the femoral neck. They said it has limited terminal arterial blood supply and the paucity of collateral circulation. They are saying the blood vessels that supply the neck of the head of femur are actually very few, and there is no collateral circulation, in the sense that when there is no enough blood coming from another branches of another nerve to supply, when the main branch supplying it is cut off. Therefore, if there is no collateral circulation, just like you going through one road, there is no other roads that can link. Therefore, if that road is blocked, she cannot. But if there are other linking roads, you can easily, if they block this place, you can easily go to another way. That is what they are saying. The interruption of vascular supply is the defining common pathway of the disease process. Therefore, here are the two heads of femur. You can see the one in green. You can see the head of femur is supplied by the branch of obturator artery via the ligamentum teres. It is wrapped around the synovial shed of the ligamentum teres. And then the neck of the femur is supplied by femoral artery via the circumflex femoral artery, the medial circumflex femoral artery. Therefore, you can still see the medial artery and the other one and the lateral circumflex. And then you can see the artery of the ligamentum teres in the black one, the black photograph, just like the other one. Therefore, that particular one that supplies the head of the femur and the femur, you can see it. A very small one, if it is cut off, they say there is no anastomosis because the other one supplies only the neck. Therefore, what they are saying is there is no enough anastomosis. That is probably the reason for the frequent death of femoral neck. Though in the black one, it appears as if there is anastomosis, but the green one appears the head of femur is supplied solely by the artery from obturator artery through ligamentum teres. But no, whatever it is, they said there is no adequate collateral circulation, and anything that happens to the only nerves, blood vessel that supplies the head of the femur, then you have a vascular necrosis. Then they said causes of a vascular necrosis of the hip. They call some diseases that are likely culprits causing a vascular necrosis of the hip. We have fractures. When there is fracture and the neck is fractured, therefore the supply to the neck is cut off. Therefore, the septic arthritis of the hip joint can cause AVN and growth plate damage. Therefore, they say septic arthritis, meaning that if there is infection and the infection affects the nerve supply, then it can really cause AVN. Then they said some disease, what do you call it? Disease like systemic lupus erythematosus, they presented that 3 to 52% of involvement occurs and is frequently bilateral. Somebody will say, why systemic lupus erythematosus? Actually, there are literatures that says it's not actually systemic lupus erythematosus that cause AVN. They say it's the steroid therapy, the steroids that is usually prescribed to these guys that actually cause the AVN, not the disease. But actually, whatever it is, systemic lupus erythematosus is there. Then sickle cell disease is a known baba in this area of causing, what do you call it, AVN. Then the other one they say is idiopathic of unknown cause. Then we have other causes again. We have prolonged radiation. Yes, for cancer therapy. You can now see part of the reason why cancer patient would have to come to physiotherapy. If one undergoes radiation too much for several months, and then it can easily lead to a AVN of femoral neck, and probably because it affects the bone health. Then excessive alcohol consumption, they believe, is one of the causes of AVN, Gaucher's disease. And then the last one is the one that defines systemic lupus erythematosus and rheumatoid arthritis. They said prolonged steroid use for the treatment of these diseases. People with rheumatoid arthritis, systemic lupus erythematosus, and asthma. For those with serious prolonged use, it may lead to a vascular necrosis because it may predispose. Since fracture, that is the link. Since fracture is one of the causes of AVN, prolonged steroid use is one major cause of fracture. Radiation is another cause of fracture of a bone. Therefore, probably they are busy radiating soft tissues because of cancer, and the bone may end up becoming fragile. If it breaks, it can lead to a vascular necrosis. Okay, we have causes of a vascular necrosis of the hip. We have two causes. Therefore, in the children, remember we said we are going to discuss two pediatric conditions. One is avian can be caused by like Patty's disease and sickle cell disease. Therefore, one of it may be sickle cell disease, another one is like calf Patty's disease. And then for adult, the most important cause is steroid use, alcohol abuse, and trauma. Therefore, if people have accident, they have trauma, they break the neck, and then there is loss of blood supply, shikenan. Then we have alcohol abuse, which actually I'm also yet to find the real cause of what do you call it, the link between alcohol and what do you call it, steroid use. Reduces immunity. Steroid use make the bones brittle and they can break. Okay. Then clinical features of what do you call it, vascular necrosis. They remain pain remain one of the most common presentation present in the groin, anterior thigh, and even the knee joint. Symptoms are of insidious onset, meaning that the symptoms are not fast, they are gradual. The symptoms ensues gradually until one realizes. Even a vascular necrosis of the hip in children with what they call CP, it may start with little hip pain and later it will become a vascular necrosis. Short swing and stand phase on the affected side may be observed. They may have even antalgic, they don't want to bear weight on the neck. Hip flexion and hip internal rotation. They said hip flexion, the hip will internally rotate. Therefore, the hip internally rotate. Pain is elicited on ROM. Pain. Then we now have imaging. This is important. Irregular motil femoral head on what do you call it? Plain films. Let me go on this. This is what they mean. If you can see the femoral head, look at it. It look whitish and irregular. The all other sides look regular and good, but the femoral head there at the tail end where you have one line is actually looking what do you call it? Irregular and mottled in appearance. Then they said MRI of both hip is indicated. Therefore, when a child presents with what do you call it, pain in the hip, and you suspect a vascular necrosis, MRI of both hip is indicated. MRI is the most sensitive in early stage. It's more specific than bone scan. Therefore, MRI is the study of tracing patients who demonstrate signs and symptoms that are suggestive of what? AVN, but radiographs are normal, meaning that when somebody comes with symptoms you think, restriction of range of motion, frequent internal rotation, pain on passive motion, and he has probably sickle cell disease and other disease, you are querying this. An X-ray said normal radiograph. They said the best is to do what? MRI. MRI may detect decrease disease as early as 5 days subsequent to an ischemic insult, meaning that they are saying MRI can detect the insults caused by this disease approaching a vascular necrosis as early as 5 days from the day it occurred, meaning that it's very specific. Here is the vascular necrosis of the femur or of the head of the femur. You can see it. The neck is okay, but the head is gone. You can. Then we have the staging of avian. We have what do you call it? 8 stages. 1, 2, 3, 4, 5, 6, 7, 6. Okay, 7. Here we have, please, in these stages, stage 1 to 3 are called early stages. Then stage 4, 5, and 6 are called late stages. Stage 1 to 3 are called early stages. Therefore, where you have subchondral collapse without flattening of the femur, flattening of the femoral head, normal joint space, all these ones 1 to 3. This is called the Sternberg classification system for a vascular necrosis. 1 to 3 is early stages, 4 to 6 late stages, and then it can also be classified as what do you call it? According to percentage of femoral head involvement. Less than 15% A, 15 to 30, and C greater than 30. But the most important is the staging. Okay. Then we are now going to look at, we have finished introduction to a vascular necrosis. We are going to look at sickle cell disease in relation to a vascular necrosis. We said is the most commonly observed complication of sickle cell disease, that is AVN. Patients with sickle cell disease or sickle cell anemia have higher incidence of vascular necrosis because their high hematocrit, what do you call it? their high hematocrit increases with blood viscosity. Somebody will say, what is this high hematocrit? Usually, there is what you call iron overload in these guys even. What happens is they may have normal blood volume. Usually, the major problem is hemoglobin is usually very low in their blood, and the red blood cells usually die. Instead of having red blood cells that will last 120 days, they will only last 28 days and they will die. The blood is filled with what you call reticulocyte. Therefore, they will say the child has blood, but they still need transfusion because he needs red blood cells that will carry hemoglobin. Therefore, what about the hematocrit that is still in that particular blood? The what do you call it? Is still there. Therefore, frequent blood transfusion can lead to high crematine concentration, and that may increase blood viscosity. Then another issue is that, remember, we talk about one of the causes of avascular necrosis is what do you call it? Vasoocclusion. And then remember, in children with sickle cell disease, there is absence of nitric oxide within the lumen of the blood vessel. Therefore, absence of nitric oxide makes the red blood cells sticky to each other and sticky to the wall of the red blood of the blood vessels. Therefore, when they stick to themselves and they stick to the wall of the blood vessel, when they get to the distal blood side, where the blood vessels are very small, they tend to block it. And that may be another cause of it. They said 1/3 of femoral heads go on to develop necrosis. Okay, avascular necrosis prevalence. Avascular necrosis occur in about 10% of patients with sickle cell disease. Therefore, 10% of patients with sickle cell disease usually come with avascular necrosis. They said hip joint is the most common site. Then evaluation avascular necrosis. They say evaluate all children and adults with sickle cell disease and intermittent chronic hip pain for avascular necrosis by history, by physical examination, by radiograph and magnetic resonance imaging. If radiograph did not give you, do MRI. And they said MRI from the five days when that what do you call it, incidence of necrosis begin to occur, it can be able to detect it. Then we have management. The chronic pain due to sickle cell disease is managed with holistic approach. It requires analgesics, it requires some nerve blocks, it requires physiotherapy and orthopedic surgery. Where there is so disabling, it may lead to total hip replacement. Where it is insidious, like early stage, it may benefit from physiotherapy. Avascular necrosis, somebody with orthopedic surgery can also benefit from physiotherapy for surgery. The medical treatment for avascular necrosis includes the use of opiate and non-opiate analgesics. Therefore, if it occurs with crisis, then opiate analgesics. If it occurs without crisis, then non-opiate analgesics can work. Then advanced form of disease require total joint replacement, THR, total hip replacement. Then co-decompression is a kind of surgery they do in the management of avascular necrosis in the early stages when the patient is in grade 1 to 3. But actually, researches have shown that co-decompression is not superior to physiotherapy. In addition to it's not superior to physiotherapy. Okay, then they said physiotherapy management. I am starting with the word that physiotherapy treatment up to date and is unfortunately not standardized. What do we mean? That is, we still do the traditional massage therapy, range of motion, thermotherapy, passive stretches, and walking education. Why? Because these guys are having, let's say, early stage avascular necrosis. When it is late stage avascular necrosis, already necrosis has occurred. Then physiotherapy has nothing to do. The child has to undergo surgery. Then post-surgery, again, physiotherapy is still indicated. That's your massage, that's your range of motion exercise, that's your moist heat or IRR, that's your passive stretches, that's your walking education is still very relevant. Therefore, we now go to the internet to find, as of today, what is the place of physiotherapy in the management of early stage avascular necrosis. Please, physiotherapy does not manage late stage avascular necrosis, it's only surgery. But early stage where there is hip pain with
within stage 1 to 3, where there is no erosion, physiotherapy can play a role. Mobility is another thing. Pain management is another thing. Passive range of motion is another thing. And where there is erosion and surgery is done, physiotherapy is also plays another role. According to Cochrane's systematic review, hip core decompression surgery that is done early plus physical therapy is not superior to physical therapy alone. Meaning that, according to this systematic review, whether a child with a vascular necrosis undergo hip decompression therapy and surgery, or he has physiotherapy alone, does not change anything. Therefore, physiotherapy, meaning that hip core decompression may not be indicated where physiotherapy is given actively. However, they said we highlight our conclusion based on one trial with high attrition rate. There is a trial, but with high attrition rate. They say Yon et al. Give strong recommendation for use of analgesics and physical therapy for treatment of what? A vascular necrosis. Yes. Therefore, whenever somebody is having analgesics and physical, and physiotherapy, it tends to manage the disease very well, whether pre-surgery or post-surgery. Then the other condition, pediatric condition that causes a vascular necrosis is leg calf patches disease. Yes, another one, actually, I want to limit myself to the two. The other one that is common to this one is, what do you call it? I will remember the name, sleep epiphysis. Okay, then we have leg calf patches disease. This is actually not an inherited disease. This is a disease that can occur to any child. Therefore, it does not have any genetic predisposition. Leg calf patches disease is an AVN of femoral, proximal femur, as a result of rapid growth in relation to blood supply. Therefore, the condition results from idiopathic loss of blood supply from lateral ascending cervical artery to the femoral head. The secondary ossification centers in the epiphysis are subject to vascular necrosis and more common in boys. Therefore, remember, in a vascular necrosis of the hip, the head and neck of the hip are the most important. But in leg calf patches disease, it's usually the neck and upper part of the something that will die. Then when they die, the head is actually going to follow them. Therefore, it's the neck and the upper part of the leg that is likely going to become ischemic. Then the head will follow it up. Then they said idiopathic temporary loss of cervical femoral head is idiopathic. We don't know. They said it's likely associated with parental smoking during pregnancy. You don't inherit, the child does not inherit it, but they said probably the mother may expose the child due to pregnancy and smoking in pregnancy, exposure to secondhand smoking in childhood. When the child is staying close to the mother is smoking, and therefore he now inhale it. They said fibrinolysis and thrombophilia. What they mean is the deficiency of thrombotic factor C, meaning that what they mean is that the body will now become hypercoagulable, just like the way we see in sickle cell disease. Therefore, thrombosis, forms, and it's likely occludes the blood vessels. Then epidemiology. It occurs in children 4 to 8 years. Actually, so many literatures are very specific on this. It occurs in children 4 to 10 years. Unlike in sickle cell disease, where adults can have a vascular necrosis. But actually, this one is certain is occurring in children 4 to 10 years. And then it's more common in male compared to female in 5:1. And the international incidence ranges from 1:750 and 1:1200 among children. And it's occur in bilaterally, affecting both hips in 10 to 20%. Then the symptom include pain and limp. Now, we as physiotherapists, when a child comes to us, this now take us back to general assessments. When a child comes limping, so many things will come to your mind. Is it that the child is having, is it a symptom of leukemia? Child does not want to place leg on the leg. Is it that the child is having juvenile rheumatoid arthritis? Is it that the child is having leg calf patches disease? Is it that the child is having, a vascular necrosis of the hip, depending on the condition? What is presenting with limp and talgic gaits? Therefore, so many things will come to our mind. That is why in history taking, there are so many things that present with similar symptoms that we have to delineate and say, okay, What is the diagnosis? Then if the diagnosis is sickle cell disease, I know. If it is cancer, I know. If it is this, that these are the likely causes. Pain worsening with weight-bearing activities. The same thing with somebody with leukemia. Then they said, now pathogenesis, death and necrosis of femoral head, we have said it. The vascular supply running alongside the femoral neck can be sensitive to changes in growth plate and other problems, inflammation and irritation. Then they now saw risk factors. They now cite malnutrition, another risk factor. Remember, we talk about mother smoking, we talk about secondhand smoking in the child, we talk about what do you call it, hypercoagulable state, deficiency of what do you call it, antithrombotic factors, thrombosis likely occur. Here they said older parents, meaning that when a mother gives birth to a child and she is old, probably the child is predisposed to this, but they say it does not appear to be genetic. Children with low birth weight, hypercoagulable state, we have said it before. Then we now have history. Limp usually over few weeks. The child keeps limping. Now, few weeks. For children with what do you call it, rheumatoid arthritis, they said up to 6 weeks. But this one, they say few weeks. Left for us to find what is the cause. But the major difference between them are rheumatoid arthritis, pediatric general rheumatoid arthritis, hip joint is not usually the major culprit, it's knee joint and other small joint. But this one, the pain is in the groin and it's mild over a few weeks or months. Pain in other parts of it you can see it can occur in what you call knee and thigh. Then it has to go for rheumatoid factor testing. It has to go for all this one. But then another thing you should look at is joint effusion, swelling in joint. This one may not come with swelling and joint effusion like the other one, but the other one is passive movement is restricted. There is pain and there is a sign of joint effusion. Okay, even the child does not complain of pain until being asked. You can see. But the other one, pain is a significant factor. Passive movement is a big problem. Now they said the child does not complain of pain until being asked. Then part of the history that will differentiate between conditions. Then clinical features. Child walk with a limb, we have said it. Pain in groin, also in thigh and knee. Muscle spasm around the hip. Then we have differential diagnosis. We have to know whether it is sickle cell disease. We have to ascertain whether it's hip trauma. We want to know whether it's transient synovitis. And synovitis has to do with what? Juvenile rheumatoid arthritis. Then we have, is it joint infection? What do you call it? One of the cause of it, septic arthritis. Slip femoral epiphysis. Please, this is one of the conditions I said. Slip femoral epiphysis is one of the causes of avascular necrosis. Slip femoral epiphysis, usually, it causes serious hip pain. Therefore, but occur in older children. That is why we didn't cover it. Then we now have physical examination. Pain increases with increased range of motion of the hip. Range of motion of the hip decreases. Antalgic gait, as we said, limping gait. Pain in groin radiates to anterior medial part of the thigh. Decrease in internal rotation. Check it. Like in the sickle cell disease, internal rotation problem, external rotation and abduction. Shortening of the involved extremity, limited internal rotation and abduction in the involved, what do you call it, hip. Then imaging, just like the way we said it in, what do you call it, in sickle cell disease, serial X-rays demonstrate necrosis and regrowth of femoral head, smaller ossified femoral head, necrotic femoral head, widening of hip joint space. But MRI can help see early signs. We have said it. MRI can help see early signs in the other hip. Okay? Then red flag, continuing pain, symptoms, or lack of improvement on X-ray. Surgical intervention may be indicated, meaning that after physiotherapy and the use of what do you call it, abduction, what do you call it, orthosis. The abduction orthosis will be discussed later, where any orthosis that will abduct the limb to fit inside the what do you call it, the head to fit inside acetabulum is what we need. But after every physiotherapy and what do you call it, the abduction orthosis, if pain continue to what do you call it, occur, then the child is likely going to need surgery. Treatment, we need containment. How do we contain? We supposition the hip to help the femoral head recover so as to close to normal. The goal is to keep the hip in acetabulum as much as possible while allowing motion. This is needed for cartilage health. The hip should be kept in abduction during recovery. Therefore, when the child is walking, the legs are not going to be together. One of the legs will be abducted small in order to keep the head of the femur. Therefore, it's as if the child is trying to work with a wide base of support. He is going to be giving an orthotic device that will abduct the leg small to keep the head in the what do you call it, in the acetabulum, allowing motion, and motion is what is going to keep the cartilage of the head. If not, the head is going to die fully. Then he needs anti-inflammatory medication. Therefore, for this child needs anti-NSAID and what do you call it? Probably some steroid. Traction therapy in the hospital at home. Therefore, the patient may also benefit from little traction where there is leg length discrepancy. The patient may benefit from little traction. Probably after the little traction, it may be manual traction, it may be a traction, what do you call it, the physio department, in order to mobilize the joint. Then conservative management, use of abduction brace. We have said it, the goal of treatment is to maintain normal spherical shape of the femoral head. The current therapy allows the child to continue weight bearing, but the femur is in abductor position so that the head is well contained in the acetabulum. The head should not come out of the acetabulum. If the head comes out of the acetabulum, the ligamental teres is going to cut off, and then the necrosis is going to be fully. Then we have, for physiotherapy, we have range of motion exercise, strengthening exercise to hip abduction, adductors and rotators. Non-weight bearing, what we call ambulation progression to pressure weight bearing. Physiotherapy can begin immediately after diagnosis. Then remember, we have talked about the orthotic device before now. Hip abduction orthosis, Scottish Rite can be worn during ambulation. It's another what do you call it? An orthosis they call what? Scottish Rite can be worn during ambulation. Then surgical tendon lengthening of contracted tissue if there is contraction. Then surgical, you can use varus osteotomy, but the most important thing is what do you call it? Surgery is performed. Then prognosis. The children can have complete recovery, especially in young children less than 6 years. Good prognosis in young children with less than 50% involvement of the femoral head, meaning that if the femoral head is not dead, if the femoral head, more than 50% of it is gone, then it is not going to be very favorable. But if less than 50% of the femoral head is, what do you call it, is involved, then applying the cast, the child is going to recover. Poor prognosis in children that is detected later. Therefore, if it is detected very later after the necrosis has already taken place, 50% of all patients have disabling osteoarthritis at the age of 50 years. Total hip arthroplasty is a typical long-term outcome, meaning that no matter what, they said 50%, just like the way we discussed juvenile rheumatoid arthritis, up to 50% of them will end up having arthritis as adults. This guy, they said, may end up having arthritis and may resort to having total hip arthroplasty as an elderly person. Thank you for listening.
Thank you, sir.
Okay, if we can recast based on what we said in the beginning of the lecture when it comes to assessment. The assessment actually cannot be in papers. Probably due to the nature of understanding of several pediatric conditions. You know, based on the history you have taken, your mind has gone to Kai. This child is likely going to have sickle cell disease related hip pain. Then you are going to, what do you call it? Your assessment is going to tilt toward that one. Therefore, if it is not so, that is why we say the assessment is ongoing. Therefore, it may be likely this particular condition. It may be likely, what do you call it, another condition. But the most important thing is that we should have array of conditions that present with hip pain, inability to put leg on ground, just like the other time when we said somebody, what do you call it, walking on toes. It may be likely to be hemiplegic CV. It may likely be to become muscular dystrophy. It may likely to be anything. Therefore, with this in mind, the more and more we get conversant with conditions, the more and more our physical assessment of pediatric cases will be tilted and will be more, can I say, holistic. We do a lot of, what do you call it, examinations so as to ascertain that this is the condition present. We thank you for listening. We have covered 5 modules today, and it was hectic. This is past 5 o'clock. Questions, comments, and contributions. Hafiz.
Yeah, thank you, sir. Good evening. Hello?
Hello, Amuchi, sir.
Okay, good evening, sir. Thank you so much for today.
Okay, thank you, sir.
I can say that we really have a wonderful presentation.
Thank you, sir.
Yeah, we really appreciate you. Yeah, my question is just for you to do a little clarification concerning the management,
Yes, sir.
physiotherapy management, okay, for the last presentation. Yes, there is you mentioned weight bearing, okay. You said non-weight bearing. I couldn't read it well before the slide went off, but I saw non-weight bearing. Do you
Yes,
mean
there is that. Do we
you
have
mean
the
that
weight bearing or partial weight bearing?
yes, okay, non-weight bearing to yes,
No, I
non-weight
think
bearing.
no, progressing to partial weight bearing with healing.
Okay.
Yes.
Okay.
Yes, I think this is
Okay,
where
I
you
think
are
I've
talking.
gotten it clearly now.
Okay. You see, what happens usually in children, sir, is that the presentation might not be the same. When it comes mildly and then it's early and the child can bear weight, then you continue with your partial weight bearing. But when the child comes with a lot of pain, therefore, as you manage the child, you can even so as to manage the child very well. You can start on weight bearing. You can give little crutches as the child is improving partial weight bearing, so as to manage the child very well.
Okay, sir. Yeah, well gotten. Thank you, sir.
Yes.
Thank you for the whole
thank
presentation.
You. So thank you. I really appreciate you. And
yeah, we have.
Yes, I wish all us what do you call it, wonderful weekend.
Yeah, we'll be
And
looking
thank you
forward
very much.
to presentation on
Sir?
I said we'll be looking forward to having more presentations on pediatric conditions.
Yes, sir. And actually, the more we have presentations in pediatric conditions, the more we get to, we will one day come up with series of presentation of cases where we say, okay, whenever it is limping, is this. Whenever it is this, is this. Then history will now be more sweet, because definitely as you are taking history, so many conditions will be coming to your mind.
Yes, thank you, sir, for the presentation.
Thank you.
Yeah, thank you, sir.
Okay, we call it a day for today. And,
yes, we'll be
we hope to make
expecting
this
the
meeting.
PowerPoint.
Yes, I will send the PowerPoints to the management of Ray today, inshallah.
So thank you very much.
Thank you, I appreciate it.
Thank you, sir.
Thank you, sir.
Well done.
Thank you, sir.
Thank you, ma.
sir.
Now good day. Thank you all.
Thank you, sir.
Thank you, sir. We enjoyed the class.
Yeah, we did.
Thank you, sir.
It's quite interesting.
Thank you, sir.
Thank you, everyone. So we meet next week for the radiological principles in pediatric conditions. Have a nice day.